We'll get started with disorders of the brain-gut axis. And for this session, it's really a pleasure also to pull all the way from New York, Dr. Braden Kuo, who's professor of medicine and chief of digestive and liver disease at Columbia University, kind of a theme here, chief after chief. And he is a leading expert in neurogastroenterology. His research focuses on GI physiology, device development, and improving treatment for patients with disorders of the brain-gut axis. He's going to discuss some abstracts from DDW and then follow with a state-of-the-art talk, and then we'll have time for Q&A. So welcome, Dr. Kuo.
Good morning. Thank you very much. For me, it's already lunchtime. So I'm glad I'm going to wake you up with disorders of brain-gut axis, DW abstracts. My approach to this is really weaving in new abstracts with just talking about brain-gut axis. I know a topic that you guys probably love clinically, but hopefully after my talk, you'll get some insights on how to apply these to your clinical practice. Some of my disclosures. So we're going to talk about key 25 abstracts in a whole host of different areas, covering the gamut from top to bottom. We're going to start with IBS. So I think in this day and age of social media and other forms of getting content, it's only natural that we are now diving into virtual reality for cognitive behavioral therapy. And these are the results of a multi-center RCT trial using virtual reality delivered CBT, showing significant improvement in IBS score and high patient acceptability and adherence. Actually, I have an interesting story about this. I saw this virtual reality thing. I placed the headset on. I said, this looks eerily familiar, desert landscape. He said, yes, that's from Burning Man. I said, oh, I get it. Now, I don't know how many of you know Burning Man, but there are definitely some CBT vibes out there. No comment. Okay, so the next thing is this concept of this palatable element diet. I don't know how many of you have ever tasted elemental diet before. I have smelled it, and it is rancid. But there is a concept that when these products are broken down into its most basic form, that they're more easily digestible, less fermentable, less likely to trigger the GI tract, which I'll talk about a little bit later. And so the key thing here is a patient actually use her own resources to develop an actual palatable elemental diet. I've tasted this. It is palatable. And, you know, I think, you know, if you're motivated, you will definitely get this down. So these motivated patients, 100% adherence at 2 weeks protocol. This is a very short-term exposure with 83% of patients reporting some symptom improvement. As a biomarker, they showed that there was breath test normalization at 2 weeks. And so this will be interesting as we evolve in terms of one aspect of modulating the diet for patients' symptoms. So some interesting pharmacology. Varenicline is a non-constipation IBS drug in development. It's a nicotinic acetylcholine receptor partial agonist. Why is this interesting? Well, it's interesting because it's a repurposed drug. It was initially FDA approved for smoking cessation, and it is being shown to reduce abdominal pain and bowel symptoms in patients with non-constipation IBS. And the reason why this is interesting is because these nicotinic acetylcholine receptors modulate visceral afferent signaling and enteromuscular function. It's a partial agonist, so it may reduce the central sensitization and gut hypersensitivity without the full cholinergic action. And so that makes it very mechanistically different than current IBS-approved drug therapies. And so we hope that this will go to phase 3 trials. It'll be a new armamentarium, not your typical chloride channel modulator, which we now have a bunch of in non-constipation IBS. IBS-C and bloating. Oh my gosh, how many of you have challenges treating bloating? I'm sure all of you should raise your hands. Anyway, I think there is original data already with linaclotide showing that if you aggressively treat constipation, you can make an impact in bloating. I think what makes this study unique is that they developed a tri-symptom response, a different type of endpoint rather than looking at just IBS global, pain global. They created this tri-response of pain, bloating, and bowel movements, and we're able to show that plicatotide, as you might expect now, moved the needle in patients with this composite endpoint. But the key thing here is improving constipation does improve bloating. Dietary intervention for IBS. Now, we all know that low FODMAP is out there for IBS, particularly in patients with SIBO. But I think one of the key things about FODMAP is it's easy to start. There's a lot of literature resources to get patients started on a low FODMAP. People are motivated to do something, because what I find with regards to dietary interventions is that that is an issue of control, and you can control your diet. But the biggest challenge is after adhering to a severe, strict, low FODMAP diet and you have improvement in your symptoms, there is very little guidance to how to claw you back to some semblance of normalcy, how you get the reintroduced food groups to be able to lead a more productive, normal life. And this is a danger because patients that adhere to such a severe diet can lead to eating disorders, ARFID, and they can also lead to nutritional compromise. And so this shows that with a FODMAP diet, you can get symptom improvement, but only less than 0.5% of patients actually get to the next level of reintroduction. And by adding a dietitian, you can actually have them guide you through that process of removal and reintroduction 3.5 times more likely. And in doing so, interestingly enough, the SIBO comorbid morbidity doesn't actually impact the low FODMAP efficacy. So ultimately, try to engage your dietitians in this process. I know dietitians are a rare commodity. They're either cash pay or rarely covered under insurance. Maybe this will be better with internet access and other different things, but this is a key component of reintroduction. This slide goes over the concepts of emerging pathophysiology in IBS, and that there really are interesting things that are being developed that could serve as either biomarkers or future targets of therapy. I've highlighted three things here. There's some RNA upregulation in IBS that could serve as a target, and this mRNA impacts colonic mucosal epithelial cells, reducing inflammation and barrier permeability. There is a crosstalk between gut microbiome and microglia that drives central sensitization in IBS. And so I think this key thing talks about how it's not all in your head because you're anxious or depressed or such. There is some biological basis to this rewiring in your brain through chronic pain stimulus. And it could be immune mediated. And then there is also the concept of duodenal eosinophils and mast cells causing mucosal immune activation is the root cause of FD and IBS. So even when you biopsy the duodenum, it may look normal. If you look carefully in certain patients, you can find abnormal mast cells, eosinophils, and subtle inflammation that may explain a group of patients in IBS and FD that might be major food responsive, because the food may tickle the GI tract and cause a shift in the mucosal immune barrier and inflammation cascade. These are still early days, but I think the key point here is we are now beginning to figure out different pathophysiological biomarkers that contributes to what we would have traditionally thought as functional GI disease. So let's focus on functional dyspepsia and gastroparesis. You know, when I think about FD and gastroparesis, the reality is the symptoms are exactly the same. Nausea, vomiting, abdominal pain, early satiation. And how are you really to tell the difference? And the only difference is a gastric emptying scan. And so that's the last point, that you can only separate that to if you bother to get a gastric emptying scan. And when I think about a gastric emptying scan, hopefully you guys are getting 4-hour gastric emptying scans. Less than 10% is normal after 4 hours. There is a cutoff of 10%. If you are 11% or 12% or 13%, you are abnormal and you are gastroparesis. But the reality about gastric emptying scans is normal physiology has a variation of 5%. So you could be 11% one day abnormal, 8% another day normal. So my book, a slightly abnormal gastric emptying scan is practically normal. And so in other words, I treat those people like functional dyspeptics. And I only reserve gastroparesis for people around the 30, 40, 50% mark. And the way I think about that is the idea that people with FD gastroparesis ultimately have a disordered neuromuscular and enteric nervous system function. It's just like patients with gastroparesis exhibit in a way we can measure with delayed gastric emptying, but they can still have enteric nervous system dysfunction, sensory dysfunction, whereas FD patients primarily have a sensory dysfunction. And if you measure them, they don't have significant delays in gastric emptying. But that being said, those patients which have bona fide gastroparesis with delayed gastric emptying have significantly higher rates of hospitalization, nutritional support, and healthcare encounters, underscoring that for whatever reason, when you add the motor component in addition to the sensory component, the outcomes are worse. When I talked about the cardinal areas of nausea, vomiting, abdominal pain, and early satiation, I use these clinically to segregate out my patients and how I think about them. And I match drug therapies based on these three different parameters. And so if I think about pain as a predominant symptom, whether it's functional dyspepsia or gastroparesis, I will think about neuromodulators, whether it's TCAs, mirtazapine, SNRIs, or buspirone. And there is a shift in sort of discussing this hierarchy of thinking and therapeutic options. So I want to highlight the drug in the middle, mirtazapine or olanzapine. There is now evidence for nausea predominant IBS and refractory gastroparesis. Where do I use it? I use it with my nausea predominant patients, whether it's FD or gastroparesis, and particularly if they have issues with early satiation or anorexia. So this is a key area that I like to push very hard for my nausea predominant patients, and who doesn't struggle with a severe chronic nausea patient. The drug at the bottom, akitinamide, is actually approved in Japan for postprandial distress syndrome. The idea here is the muscarinic modulation targets fundus accommodation. If your fundus doesn't stretch appropriately or is hypersensitive, that can cause early satiation. Just sort of validating another pathophysiology aside from just pure pain, and that this drug is being looked at in clinical trials in the US, even though it's approved in Japan. A little bit more about the pathophysiology. There is now interesting duodenal microbiota dysbiosis driving the immune activation in FD symptoms. Now, this is not ready for prime time. You can't just take a biopsy, send it somewhere, and all of a sudden you have all these different pathways worked out that you can target. It's early days, but I think it's very exciting because it offers you greater insight and potentially options in the future aside from just treating them with PPIs. And we know that there is limited impact on that, or even neuromodulators. Post-COVID functional dyspepsia. This is a growing subtype. Now, you can understand with COVID, immense immune reaction in patients. And, you know, we've been writing about this for a little while, wondering there should be an avalanche of functional dyspepsia, IBS coming through because of this severe inflammation. And certainly you see patients with long COVID symptoms having these sort of issues, whether it's neurological, brain function, and GI tract. So there is an 8 times risk of developing functional dyspepsia compared to non-infected controls, which may relate to the inflammation impacting duodenal mucosal permeability, immune activation, dysbiosis. The last part is H. pylori. We know that it can have an impact on functional dyspepsia, but if you, in real world data, people underdiagnose and undertreat H. pylori, it may be an issue that it should be better aggressively managed at the primary care level, but you should consider looking for it and eradicating it with regards to functional dyspepsia, particularly if you're in a high prevalence place. DGBIs and eating behavior. I don't know if you've heard of this term, ARFID. It is out there. It's emerging. We helped develop this term as application to GI issues. Its ARFID is associated restricted feeding intake disorder. This is actually a DSM-4 5 criteria, a bona fide eating disorder. It came from the pediatric group where it was really the picky eaters, people that didn't like celery or their vegetables. It's evolved into the adult world because basically you have patients that have pain, nausea, vomiting when they eat, as negative reinforcement symptoms, so that if they get these symptoms, they eat less. And then the cycle viciously continues. They eat less and less because they don't want to drive their symptoms. Now, you can debate about all the different reasons why these exist, but that self-reinforcement behavior is documented and can exist. And so there is, if you apply certain criteria, 56% prevalence of ARFID in functional dyspepsia, 50% in IBS. And if you combine the two, even a higher prevalence. Why is this important? The most challenging patients that I see who have dramatic amounts of weight loss with dyspeptic symptoms have a version of ARFID that you can identify if you look for it. If I can identify it, then that helps justify why CBT or another different type of cognitive behavioral therapy, which is a mainstay for this type of eating disorder, can be applied. Do they have a disorder equivalent to anorexia nervosa bulimia? For patient relations, I would say no. You do not want to communicate that message. But I think understanding that process shifts the framework and how you approach these patients, thereby opening up a wider assortment of treatments if you can make the patients acceptable to this. Gastroparesis and motility, GLP-1s, common now out there. It impacts gastric emptying. I think that certainly increased risk factors for diabetes, post-gastric surgery, and being on GLP-1s. I think one of the interesting areas is GLP-1s. Do you hold it? Do you not hold it? How long? Which case? And such. And I think one of the interesting areas is the emerging use of endoscopic ultrasound. Not endoscopic, abdominal wall ultrasound to look for gastric contents. And there are very few anesthesiologists that are trained to do this. We are evolving in our use of bedside ultrasound. I think this is a unique opportunity for GI to take that back and possibly screen our at-risk patients with a bedside gastric ultrasound to look for remnant material and then appropriately risk stratify them with intubation or conscious sedation. And then the last bucket there talks about how GLP-1s delay gastric emptying by various mechanisms. But most of the time, if you study these people, 4 to 12 weeks, the function does return. Another interesting area of gastroparesis development is not using drugs, not using invasive neurostimulators, but non-invasive neuromodulation. And so this is a magnetic stimulator. It's basically a magnetic wand with a circle. When you turn it on, it drives electricity or energy into the wall, and that may modulate nerve endings. And this is a small study and further substantiated by the NIH trial that I was involved in that was reported this year, showing that it's a non-invasive magnetic stimulation and you can get significant symptom reduction. And we're still evaluating the durability, but this is a non-invasive neurostimulator rather than potentially invasive gastric pacemaker. Poem. It's out there. There are interesting things. We're trying to figure out who's appropriate for it. Here it shows a 4-year G-POEM durability of 50 to 65%, clinical response rate maintained. And diabetic gastroparesis consistently outperforms the other type of subtypes. There are some biomarkers potentially to predict people that might respond. That is, if you take a full thickness biopsy while you're doing a pyloric myotomy, there is a correlation between ICC interstitial cells of Cajal density and fibrosis and superior outcomes. And if you do it once, we are now seeing experienced operationalists being able to technically do it again in patients and those who have relapsed. This slide talks about some emerging pathophysiology that's been highlighted. The idea that ICC cells, these pacemaker cells of the GI tract, does correlate with gastric emptying, so that when there's depletion, you have less neurological function and less emptying. There's also anti-inflammatory processes like macrophages that derive this pacemaker cell depletion, and that you can see this process both in diabetic and idiopathic gastroparesis. I think signifying that no matter where you started from, eventually with gastroparesis, it may end up being the same sort of ultimate process. Now let's talk about nausea vomiting. Cyclic vomiting syndrome. I don't know how many of you guys see this in gastroenterology. If you do not see this, you are not looking for this. This is a history diagnosis. This is not a diagnosis by any type of test. Symptoms of severe nausea, vomiting, abdominal pain, likely to send you to the ER and inpatient, and then in between, symptomatically completely fine. If you can elicit this therapy, this is a super win, because compared to gastroparesis, many mild to moderate patients can be effectively treated with prophylactic agents such as TCAs. And there is a protocol to deal with these patients when they're an inpatient. The most common issue I find challenging with these patients is when they get sent home, they're not on prophylactic therapy. There are a lot of corollaries of CVS to migraines. Do you send home a migraine patient after a severe attack with no therapy at all? The answer is no. Same thing with these types of patients with CVS. And there's also now graded stepwise therapies that have become a little bit more sophisticated in terms of managing these types of symptoms. But in addition, aside to drugs, there's also gastroenterology, CBT, that can be helpful for managing this. Cannabinoid hyperemesis, CHS, just one sentence. It is rare. Just because you smoke a little weed does not mean you have cannabinoid hyperemesis. The criteria are intense, regular, daily, heavy smoking for a significant period of time. And then if you stop it after 3 to 6 months, symptoms go away. And so when I see patients, I encourage them to stop it. I talk about the level of cannabinoid use, and two hits a week does not qualify as cannabinoid hyperemesis. Let's move down further down and talk about gut-brain axis, psychogastroenterology. I think here the idea is CBT cut its teeth in IBS. And what we're showing now is that you can actually apply these same techniques to functional dyspepsia, the upper GI tract, and the esophagus. There are now a lot of clinical trial data showing different ways of delivering psychogastroenterology, digital health, technologies, videos, and such. So we're expanding that access that I think is extremely important. This slide talks about how there is more DGBIs after COVID. Surprising to me, it's I'll talk about this a little bit later. It's not as high as I would have thought, but definitely appreciably higher. There's machine learning in trying to figure out how motility, if you feed in all the data, can lead to a diagnosis of DGBIs. And an interesting concept here, I often talk to patients, when it rains, it pours. So you see the patients with fibromyalgia, Ehlers-Danlos, POTS, and DGBIs. When you have all those things, you can imagine your comorbidity is far worse, needing a lot more resources to manage them. So thank you very much on this section, and I'll take questions after the next one. Thank you. Okay, we're going to go on to state of the art. These are some of my disclosures. Here, we're going to talk about the global epidemiology of DGBIs and the documented rise in COVID. Talk about, I think, the emerging pathophysiologic mechanisms. This is a key point with regard to DGBIs because we are evolving from just a pure psychological diagnosis, a wastebasket diagnosis, to really some pathophysiologic underpinnings. There are new Rome criteria introduced this past year in DDW 2026, which have updated the framework as well as the IBS pain threshold. We'll talk about some select pharmacological, dietary, and brain gut behavioral therapies and identify these issues as a new era in potentially precision medicine, pharmacogenomics, and microbial therapies. So the global epi of DGBIs, 40% of the global population, a lot of patients, 40% met the Rome 4 criteria. It's the number one bowel disorder that you guys see in your clinical practice. And the by region, if you look at the bottom, it's still high prevalence in the lower GI tract, a little bit lower, but still very high in the upper GI tract. Anal rectal region still has quite a lot. Esophageal has a little bit less. Post-COVID burden of DGBI. It is a rising crisis. You know, when I was thinking about this, I was waiting for that avalanche of patients, like 30-40% of patients to show up. And they are showing up. The change is there. As you can see here, 4%, 3%, 1%. So not as much as I would have thought, but still present. Mainly risk factors include the number of COVID infections, the number of GI symptoms after COVID illness, having long COVID syndrome, and certainly anxiety and depression before and after infection. So this is an important slide to shift the framework of DGBIs from functional to mechanistic. Here we're talking about three large broad-based categories of mechanistic reasons why you might have DGBIs. Epithelial barrier dysfunction, where the tight junctions may be dysregulated. You may have this, the concept of leaky gut is real. I know we roll our eyes when we hear about it, but you can pathophysiologically measure it. You can't measure it in the clinic, We don't have great treatments for this now, but these are pathophysiologic contributions to the process. There's stress dysbiosis, food components where food may break down, food reactions may break down the epithelial barrier. And there are markers for this, but they're not ready for clinical prime time. There is the immune mucosal activation. Mast cells degranulate in response to antigen and stress, food that you eat. And eosinophils can accumulate, and you can biopsy this. And this all triggers a cytokine milieu. Food antigens such as wheat, soy, and milk can trigger this cascade. And you can measure mast cells, but we're not quite there yet clinically, but there is emerging evidence at the animal and pathophysiological level. And then there's a microbiome and the epithelial crosstalk, where the gut microbiome produces all sorts of important things. Short-chain fatty acids, butyrate, bile acids, tryptophan metabolites that act on the endocrine cells, immune circuits, and vagal afferents that all serve to maintain the mucosal barrier. And so this dysbiosis can lead to dysregulation, and translocation with dysbiosis can lead to low-grade inflammation. You can have abnormal metabolites of the tryptophan. The bottom line here is there are targets that we have right now that we use, prebiotics, probiotics, postbiotics, and fecal microbiome. They have varying effects, admittedly, because I think this whole process is complicated, but there is evidence to show why these things could make some benefit. So, in many ways, I want to reframe DGBIs from functional GI disease to really neuroimmune mechanisms, where you might have some food exposures, whether it be wheat, soy, and others that trigger the immune system in sensitive patients, triggering some sort of Ig-independent mechanism. You got mast cells and eosinophils, particularly where the food gets absorbed in the duodenum, that releases all sorts of things that could be modulated, histamine, tryptases, and proteases. You have the pain component, the nociceptive mediator release, here histamine, serotonin. These affect and sensitize the neurons in the gut. You can measure this. And FODMAP, this is where FODMAP can modulate some of this. And then the concept of overall sensory sensitization. If you have your symptoms for more than 3 months, there is eventually maladaptation within your brain, causing an exaggerated response. And that is why you can't measure this exaggerated response clinically with our current tools. You can measure this actually in research studies, where if you tap somebody repeatedly, people that have central sensitization feel the tap differently after the 10th tap in more pain than they do. And normal people, 10 taps is the same from the first one to the 10th one. So what are some of these mediators? Short-chain fatty acid. This is the idea of where fiber really works. Fermentation of the dietary fiber releases these short-chain fatty acids. Butyrate is one of the most common ones, and it impacts the colonocytes, immune cells. And this ultimately regulates motility, mucosal integrity, and satiety. Bile acids come from the liver and also from microbiome transformation. And they have receptors that affect the endocrine cells. So this also regulates gut motility. And you have tryptophan. This is the whole turkey thing where you get sleepy after eating Thanksgiving. This actually comes from microbial tryptophan catabolism. So you eat the turkey, it gets digested and metabolized the microbiome in the gut, and that can also modulate immune tolerance, intestinal barriers. And then you have all these lipid mediators that can change the sensory neurons. So the point here is there is this complex interplay that's now starting to drive many sensory or DGBI processes. And how does this play into the Rome network? So I think in the past, the Rome network, Rome criteria was focused on the biopsychosocial model on the bottom here, where you talked about psychological comorbidity, life events, and coping style as contributing to the DGBIs. But now in Rome 5, they fully acknowledge that you have all these other components, the dietary, nutritional component, the gut microbiome, the pharmacogenetics, and even the gender cross-cultural issues all contribute together to these disorders of brain-gut interaction. I think in many ways explaining a much more complete model for the clinician and the patient. So there is, this sort of lists out some of the diagnostic tools that exist and where we stand in terms of the validation. The Rome criteria questionnaires, they're clinical use, they're validated, but they're just questionnaires at the end of the day. And all these other things that I think I've mentioned to some degree about in terms of understanding the mechanism. They're all still research days, promising biomarkers and such, not things that we use clinically, but over time, I think some of these will evolve. So in Rome 5, 2026, there's an updated framework. There was an updated DGBI definition on some of these things. They expanded the framework, as I talked to you about before, outside of just disorders, outside of just the psychosocial dysfunction. By doing all of this, they're trying to reduce the stigma and by removing the word functional. So functional dyspepsia does not exist. It's just dyspepsia. And I think that goes a long way because names have power and meaning and impact. I'll talk to you about some updated thresholds for some of these diagnoses, but the inclusion of the patient and cultural experience, I think, is interesting and sort of highlighting the fact that DGBIs have a global impact and different cultures and different life experiences contribute to that process. So what has changed between Rome 4 and Rome 5? 10-year evolution. Remove the term functional and call it just bowel disorders to remove the stigma. IBS pain diagnosis has changed. The pain frequency used to be rated 1 time a day, which was higher specific but lower sensitivity. The reason why that has an impact is it changes the prevalence of IBS, and probably with that criteria identified more severe patients, which is interesting, but it will make probably clinical trial development harder. So they changed it to 3 days a month, improving the sensitivity while maintaining the specificity. Remove the word functional. So now instead of functional constipation, it's just chronic constipation. The diarrhea onset is lessened from greater than 3 months to just 8 weeks. New DGBI categories evolve from the biopsychosocial model to all these other pathophysiologies that can contribute. So again, greater than 1 day per week is now greater than three times per month. Very important distinction. So that I think that broadens the categorization of patients with IBS. I think this slide highlights the idea that oftentimes these things don't live in isolation. Even with gut motility, the GI tract is one long tube. If you have areas impact in one area, it stands to reason that it's highly likely that you're going to have other areas impacted. And this just shows you that there are different levels of areas of impact, but they are common and frequent. And so if you recognize this by applying certain types of therapies, such as cognitive behavioral therapy, dietary modification, and even pharmacology, you may be able to impact multiple symptoms at once. I want to review. This is the 5-step clinical model for DGBI management. Make a positive diagnosis. It is not a diagnosis of exclusion. It is a diagnosis of inclusion by applying the Rome criteria. Empathy. Now, it can be hard to empathize with 5-minute visits and stuff like that. I think in many ways, the most powerful tool that we have for these patients is time. Time equals empathy in many ways, where you acknowledge the symptom legitimacy and validate what they're feeling to build trust. Because that trust then leads to education and setting expectations. So you're shifting, and we all have those patients that want a cure. They want that one thing that if you fix, their problems are going to go away. You have to shift that to realistic expectations while preventing therapeutic abandonment and reducing patient frustration. So you have to set the tone of how you interact with these people and that you are trying to improve quality of life, not cure. And then understanding that there are a whole host of things to treat these patients besides just 25 milligrams of amitriptyline and then stop. So speaking of amitriptyline, first line TCAs, the most studied and actually a class for brain gut disorders. The Atlantis trial in primary care showed benefit at 10 to 30 milligrams at QHS. SSRIs, modest benefit, but still present for abdominal pain for both functional dyspepsia and IBS, particularly if they have anxiety, depression. SNRIs are emerging, some data there, but not as big as the others for pain benefit and mood benefit. I think the gabapentins, I use a lot of these in my clinical practice. There need to be more trials, but there is some benefit with pregabalin and functional dyspepsia. And I really think about these things with regards to the pain component of patients. and I talked about mirtazapine for nausea predominant. The key thing that I think separates a experienced motility doctor or an experienced DGBI practitioner from your average is knowing the side effect profiles of these medications, how to harness the side effect profile for the patient's benefit. If a person has severe constipation, I'm not going to use amitriptyline because the anticholinergic properties can make the constipation worse. That's one of the most common mistakes that I see, and I might use these second-line agents. I may not have the evidence for this because designing clinical trials for this type of clinical practice is extremely complicated and difficult. The other area that I actually have a lot of success with is it's not like I create new medications, but I stack medications. I will take a medication like an amitriptyline. I'll run it all the way up to its max dose. I will leave it there, even if I didn't completely cure the symptoms. But if I move the needle on their symptoms, even 10%, I will max it out and leave it there. Then I will start a completely different agent on top of that for synergistic effect. So the common failure I see is not pushing the dose fully, or you keep on moving from medication line to medication line to medication line with not significant moving needle results. And that's where stacking these medications can have an impact. But feeling comfortable mixing the TCI and the SSRI because you don't get that epic blip of serotonin syndrome and pushing past that process. Dietary interventions are present. They're available. They make a difference. They're not a panacea, but they definitely have a rationale. And there are many different approaches. The gluten-free, wheat-free diet with IBS, even if they don't have celiac. The Mediterranean diet with its anti-inflammatory properties and microbiome diversity has some evidence in IBS. Carbohydrate specific, not really that great evidence, but it's not a standard approach. And the elemental diet is intriguing, not yet mainstream, no long-term data. Brain gut behavioral therapies. This is an area I think that we've experienced some immense growth. First of all, the validation that these therapies can exist. Then becomes the question, we don't have a GI gastroenterologist on every single corner. We do have a therapist on every single corner and even virtually, but they are not necessarily specialized in this area. So how can we deliver better care for cognitive behavioral therapy, gut-directed hypnotherapy, and mindfulness stress reduction? It's really through digital therapeutics. They are FDA approved. There's evidence from randomized controlled trials. There are virtual approaches to all of this, group therapy approaches to all of this to help deliver this care. I'm not saying that these behavioral therapies are panacea. They are an important adjunct, particularly in moderate to severe patients. They can help move the needle in combination with many other things. With functional dyspepsia, this is just moving down the list of what we should consider. Most of you all consider acid suppression, even primary care doc. That's easy to do. What I find is that many gastroenterologists don't take it to the next level of using neuromodulator. And there is evidence for use of amitriptyline in functional dyspepsia. The key thing about that is that if you have delays in gastric emptying, if you measure gastric emptying scan in functional dyspepsia, and FD is allowed to have some abnormal gastric emptying delay. Remember I said mildly abnormal is practically normal. But the clinical trial evidence would show that if they have delays in gastric emptying, even if it's mild, TCAs are less effective than, not as effective than if they had normal gastric emptying. So I screen my patients with upper GI disorder with gastric emptying scans for that very purpose of determining whether I would push TCAs in these patients. There are other motility agents. I frankly think most of them are limited because you can measure motility, quantify it, but you can't easily measure the other neurosensory component, which I think contributes many times even more to the patient's condition than just pure motility. And then there's this emerging area of immune and eosinophilic targeting. There are interesting drugs that are right now have mechanistic rationale, but still are not ready for prime time. Clinical trials are happening. So the emerging frontiers, I just want to highlight, there are pharmacogenetics where people that may process these neuromodulating drugs process it differently. TCAs, SSRIs, same dose, they process it differently. This has been shown in psychiatry. We can show this in psychogastroenterology, but we're not ready for prime time, but this can be a factor. Functional microbiome markers, we can measure the microbiome, but not a day goes by they're saying, I want you to treat my microbiome for IBS. The data is not there yet. We're not sophisticated enough to shift the microbiome, but it can be an interesting biomarker. Personalized dietary interventions, rather than using the blanket low FODMAP, and I showed you before, just because you start on low FODMAP doesn't mean you've finished the journey. You have to get them back to reintroduction and tolerance. And I think that we are have to evolve in how we personalize our dietary interventions. There's some interesting technologies on a patient level where they can see some of these biomarkers before they eat, after they eat, and how they respond to how these biomarkers respond to different dietary interventions. So we're evolving that direction. Treating the mast cells, still a area of evolution with some, but exciting. And if you take all this information, you can begin to potentially personalize your treatments. I don't have the ability to use all this information yet to personalize, but I'm excited about this possibility. And we'll just have to see how this evolves down in the future. This slide highlights the idea about IBS-C versus chronic constipation. In the past, this was treated as two separate entities. You either had IBS-C or functional constipation. Now you remove the term functional and acknowledge what we've seen all the time in our clinical practice. This is a spectrum. People evolve. Some days, if you have pain, you're IBS-C. Other days, if you don't have pain, but you have altered bowel movements, you're chronic constipation. And that is why many of the drugs that we use for chronic constipation also have an IBS-C indication, because in many ways, these patients are the same patients. They just switch their phenotype on a weekly or monthly basis. This slide goes over the concept that constipation has different flavors. A key point that I teach with my GI fellows, there's the pain predominant constipation. Frequently, they complain of constipation symptoms, but if you measure the transit, it actually is normal. That doesn't mean they don't have constipation, but you have to think beyond just moving their gut motility to treat them. And that's why neuromodulation to treat their gut sensitivity of normal feeling sensations, which they interpret as constipation, can be ameliorated. So this is a subtle point that a lot of practitioners don't go after. They're more used to the slow transit constipation, where you can use a Bristol stool scale or just assess by frequency. And that's where dietary fiber therapy, hydration, physical activity, and then osmotic laxatives, stimulant laxatives, and secretagogues all fit into that. And that's what you're used to. I think you probably recognize that there's evacuation disorders and outlet features. You need to ask for it. And many times constipation is just free form. They talk about bowel frequency. They talk about straining, but they treat them all as slow transit. And by identifying straining, incomplete evacuation, digitation, if you don't ask for that, if they manually disimpact, they will not volunteer that for you. So you should ask for it every single time. And this helps identify the dysenergic defecation population. This is important because if you just treat them with laxatives and they have dysenergic defecation, that means you're pushing all that material to a broken trapdoor at the end. The trapdoor, they still will have constipation. So do the digital rectal exam, do the anal rectonometry, where the balloon expulsion test is the easiest test to show, where if you fill a 50 milliliter balloon and they can't expel that after 1 minute, they have dysenergic defecation, and sending them to biofeedback. I realize biofeedback is a limited resource. We need to improve upon that different ways, but that is important option in terms of treating our constipation patients. This slide goes over the fact that there are many different secretagogues out there, each dealing either with sodium channels, chloride channels, generally very safe, may have some impact on neuro sensations and neuromodulation, but focus heavily on fluid secretion and bowel movements. And we talked about how important it is to diagnose dysenergic defecation. It is so common. I would say in most of my refractory constipation patients, it's present. And if you are ever thinking about sending a person for a colectomy for constipation, I've only sent 2 in my entire 30-plus year career. It's because dysenergic defecation has not been adequately treated or recognized. You have to treat it, and make sure by repeated testing that it is functional before we would even consider a colectomy. And so there are some key guideline consensus updates that I've talked to you about before. I think the key things are the change in the Rome publication, including bloating, chronic pain management, and the role of diet. And so the key takeaways, DGBIs are common. We are evolving from it being a biopsychosocial model to a more mechanistic pathophysiology. Rome 5 criteria relaxes the IBS pain thresholds. So now it increases the sensitivity while maintaining the specificity. TCAs remain the first line of neuromodulation, DGBIs. There are other drugs, but I think in the more sophisticated care, you will probably end up having to stack these medications. FODMAP is useful, but most people forget to move them beyond just elimination to reintroduction. Gut-brain behavior therapies are present. They now can impact up and down the entire GI tract, and we need to expand the access in different ways. And we are ultimately moving to precision medicine, where these things like pharmacogenomics, microbiome biomarkers, mechanism-based patient stratification exist. It's much like the idea of liver biopsy and understanding different types of liver disease that exist. If you don't understand these, you don't target the therapy. And I think we are in early stages for that, but it's exciting for the future. Thank you very much.
Thank you, Dr. Kuo. I think in many years of hearing talks on this topic, that was the most energetic and comprehensive talk I've ever heard. We've got a question.
Energetic at 9 in the morning, right?
Yeah.
Yes. Energetic at 9 in the morning.
Thank you for your talk, Dr. Kuo. Couple of questions. Wireless motility capsule and allimetry. Do you use them in your practice? I know the data is still young. I've been talking to the reps for the last year. Sounds very exciting, but still I'm not quite certain it's going to change my management of these patients. So that's the first question.
Sure. Well, first of all, as a matter of disclosure, I've been heavily involved with the wireless motility capsule development process. But one thing I want to take away with that is the most useful result of any motility test is a normal finding. And so patients come to me complaining of abdominal pain, diarrhea, constipation, and certainly I can give them questionnaires, but these are subjective evaluations. What I love about motility testing is not that I'm actually going to find motility abnormality, slow transit constipation that I act upon. What I love finding is that you're complaining so much, but objective testing shows the transit is normal. The allimetry is normal. What does this mean to me? This means that I can shift from pushing the motility to addressing that other component, the sensory component, of which I talked about a whole bunch of different options for. And that's where I think a lot of patients and doctors get stuck, is they don't move beyond that level. So I do think motility testing, whether it be allimetry, wireless motility capsule, is helpful, because if you're normal, then you can really shift the paradigm of treatment in these patients.
Great, thank you. Second question, autoimmune GI dysmotility. So I'm really excited by, of course, the different mechanisms that are currently investigational, and I think there's a lot of promise in how to phenotype all these patients. Where do you think the autoimmune category, fits into all that? And I was talking to one of the physicians at Louisville about IVIG use.
Of course, I know Tom Abel, right?
Yeah, and I tried it on 2 patients. Unfortunately, it didn't work, but I don't think we had the right tools. All the autoantibody panels, I think, are also a little bit, not completely worked out yet. So just wondering what your experience is.
Right.
In this
so
area.
I think a couple of things. Number one, patients with autoimmune disorders, I see plenty of them with GI dysfunction, whether that's exhibited as autonomic dysfunction, sensory dysfunction, and such. So clearly, this immune environment does make things worse. I think we're still stuck at what is the right therapy. And I think the challenge there is probably we need better ways of phenotyping. So IVIG has been pushed out there as a way. Certainly our neurology colleagues have been pushing that. I don't personally prescribe it. If I think that they may benefit, I sort of push them onto my neurological colleagues. Usually they have concomitant other neurological things to do it. Have I seen overwhelming response? The answer is no. It's a lot of resource. So I think the bottom line is this is a lot of great theory and hope, we still need to work a lot of this out.
Thank you.
Thanks, Dr. Groh. That's great talk. So question on, many patients with like epigastric pain, you do an EGD and you see a little, erythema in the duodenum, you biopsy, you check for H. pylori negative, and you kind of let it go. So the whole slide on this eosinophilic infiltration with mast cell activation, and I know it's not hitting prime time yet, but is that worth asking the pathologist to check for like mast cell staining? Many patients with functional dyspepsia, they stuck on the idea that it's not real. But if you have something that can actually prove it to them, is that worth even asking for it in this situation? And the second component to it is, how is this different than someone with eosinophilic enteritis? I know this whole cutoff for biopsy in the duodenum with eosinophils 125 to 30 per high power field, but where are we fitting with that?
Sure. So let's take the second one first. It's a matter of scale and degree, right? I mean, when you talk about eosinophilic gastritis, you're talking about outright, very demonstrable immune mediators that you can easily characterize in our current pathological system. So there, with that level of obviousness, then we feel more justified in aggressively treating with immune modulation. But I think the bottom line is I am loath to go after things that I don't have actionable treatment because it ultimately confuses the picture. So the classic is, you're teaching a fellow endoscopy, they go, oh, there's a little bit of erythema there, that's gastritis. I'm like, no. You do not call that gastritis, because if you do that, then you're going to go down this whole pathway of chasing things that are not going to have any impact. And so my general, I mean, there's the hypothetical and the research, but the practical is, if I do not have an actionable pathway for my diagnostic finding, I'm not going to look for it because it only confuses the picture. So if you're asking me now about the duodenal biopsies for mast cells and all that stuff, you would argue, well, you can treat them with histamine blockers, and maybe that will make a difference, or mast cell stabilizers. And so, there's a camp. Nick Talley certainly pushes this very heavily, that they do improve, not from the acid suppression, but from the histamine modulation. I'm not quite there yet, to be honest with you. So I don't blanketly treat my patients. I don't randomly biopsy people aggressively for this sort of stuff, because I don't think the strength of the evidence is quite there, but I'm excited about the possibilities, but not there yet.
Thank you.
Dr. Gertler.
Yeah, thank you. I wondered if you would circle back to cannabis hyperemesis. It seems like it's something that we see all the time. You implied that maybe it's overdiagnosed.
Sure. So I think it's overdiagnosed because, again, if there's a history of any sort of cannabis, that gets labeled. And I think this is a big problem because labels carry meaning, and the patient has a pejorative, it's pejorative. It influences our care of them, saying, well, if you just stop your marijuana, your problem should go away. I think also patients feel that they're targeting the marijuana, that it erodes the patient-physician relationship in trying to impact them. And so in these complicated patients where marijuana is a question, I'm just outright in saying, I ask several important questions. Number one, if you're doing marijuana, are you doing it recreationally or medicinally? Many patients take it because they are using it medicinally for anxiety, stress, pain, and nausea. And I ask them to quantify it. What percentage of it is medicinal versus recreational? If I find that they have a higher percentage of medicinal, above 50%, then I can tell them, look, I understand where you're coming from, and control and access are extremely important, but we have other medications that you can use to decrease that threshold of those other symptoms and take you off maybe your use of marijuana that may have less long-term side effects. If they say it's heavily recreational, then I say, well, look, how badly do your symptoms bother you? If they bother you so much, then try 2 months, 3 months. And what I mostly find is 3 months of cessation does not make their symptoms go away, which makes me believe cannabinoid hyperemesis is much lower prevalence than what we attribute it to. And thereby, I accept that they were going to use some marijuana for whatever reason, whether it's medicinal or recreational. But then I tell them, on top of this, Clearly, that's not helping your symptoms enough because you're coming to see me. We have to add these other layers of therapy to try to move the needle in you.
Just a follow-up question about nomenclature. So naming matters to the patient for this as well as other things. Certainly with disorders of the brain-gut axis, it matters. You mentioned doing away with functional dyspepsia, but every slide that everybody does, or Nick Talley's, New England Journal of Medicine review still says functional dyspepsia, and we still say IBS-C and IBS-D. There are ICD-9 codes. This matters not just to the patient, it matters for clinical trials and development. What's the new name for functional dyspepsia? Because it's not just dyspepsia, because there's uninvestigated dyspepsia, there's ulcers, there's, there's epigastric distress syndrome, there's bloating. How are we going to do naming?
I will tell you, there is a huge coming to reckoning moment with this in the next 5 years. There are people that hate the term DGBIs, and I understand why, because they're saying by that name and implication, it's just maybe slightly more palatable than functional, but it's still saying that there's something wrong in your brain that's contributing to all of this. And there's a strong movement really trying to change all of this. And so I think in the next 5 years, now that psychogastroenterology has been accepted as one mainstream process contributing to this to all of this, that there's going to be intense discussions, painful discussions with a lot of strong opinions over the next five years. And I suspect in 5 to 10 years with Rome 6 that these will be partially worked out.
So it'll be more like MASL is now.
Yes.
Yeah. Okay. Sasan.
In terms of just a practical question, elderly patients with gastroparesis, documented gastroparesis, cardiac history, maybe arrhythmias, what's your thought on procalipride, or what's your go-to? How do you keep them long-term on, domperidone, on Reglan, et cetera? And when is, on the follow-up, when do you think the percutaneous stimulator would be available?
Sure.
In the community?
So this is sort of how I evolved in my gastroparesis thinking. I talked to you before how, number one, you need a gastric emptying scan to make the diagnosis, distinguish from functional dyspepsia. And again, the broader rubric of how changes in the enteric nervous system can produce both motor disorders and sensory disorders. We can measure motor disorders in gastroparesis, but I find the most challenging patients in gastroparesis, it's not the motility disorder that's contributing, it's a sensory disorder. And we focus all this time on improving the emptying, cutting the pylorus. When I find the majority of patients, I can move the needle by neuromodulation and other sort of non-invasive approaches. So I personally don't refer a lot of patients for GI-POEM. I personally don't place invasive gastric stimulators. I use actually the whole host of other neuromodulatory medications, cognitive behavioral therapy and such to move the needle on these patients without committing to more invasive approaches. And I feel as somebody that's really a quaternary referral on this, I might be a little bit different than the others, but I do feel I'm making a difference in these types of patients. And so I don't push forever erythromycin unless that gastric emptying is above 50% delayed or procalipride. I'll leave it there, but I fully believe that just moving the motility doesn't move the needle on a lot of these moderate to severe patients.
Thanks.
Okay, no other questions. Thank you so much.
Thank you very much.
Welcome back to hepatology session. I think we want to start on time so we can finish on time. Thank you very much. We had a very good GI sessions. We're moving to hepatology session. I'm Ke-Ching Hu, Director of Hepatology Service, Professor of Medicine, UCI, the planning committee member for this symposium. As you can see from our agenda, we have 3 great world-class speakers on some liver heart topics, and then we have a panel for further discussion. So it's my great pleasure to introduce our first speaker, Dr. Jessalyn Thin. She is assistant professor and transplant hepatologist at the UCLA Liver Transplant Center. She actually received her medical training in Ohio University and medical resident and GI fellowship training in Loyola University. After that, she has received her transplant hepatology training in USC Keck School of Medicine. She is active researcher in alcoholic liver disease, HCC, and MASH. I enjoyed her previous talk before too, so we're so happy she's here. Her talk will be advances in muscle D from diagnosis to risk stratification and management. Jocelyn, thank you.
Thank you, Dr. Hu, for the introduction and for the invitation to present on this topic. So I will say this is a lot to discuss for 25 minutes. So we're just going to go through the greatest hits, if you will, of MASH, MASLD, and some updates. So going through some of the objectives for this talk, we'll be discussing, I put it in quotes, new nomenclature that's been around for a couple of years now, but just so that we're all on the same page about how we refer to our patients with MASH, previously NASH, briefly touch on some epidemiology. We'll discuss fibrosis assessments, so both lab-based and imaging-based modalities that we have available, especially since we're moving away from liver biopsy. And of course, we'll talk about treatment of MASH, MASLD. We have 2 FDA-approved therapies, and then also just briefly touching on drugs that are under investigation. So very exciting time for MASH, MASLD. So going right into it. So NAFLD's out, MASLD is in. So, there were a couple of reasons for this, actually probably multiple reasons, but, I would say the top 2, one being that, in an effort to sort of destigmatize alcohol-related liver disease. And the other thing is to highlight the importance or influence of metabolic syndrome on our fatty liver patients. And so, there's an umbrella term, and we'll go through in a little bit more detail on the next slide. But this just basically highlights this umbrella term of steatotic liver disease, which encompasses MASLD, MASH, which is the inflammatory component with the steatohepatitis, and then MET ALD, which you'll be hearing more about from Dr. Lee as well, which is basically MASH, MASLD with increased alcohol consumption. And so it's good to finally have a term to use for that. So as I mentioned, steatotic liver disease is considered to be more of an umbrella term. Just focusing on the left-hand side of this graphic, you can see that, MASH, MASLD, and then this MET ALD, which, really highlights the influence of alcohol use on the progression of liver disease. And so you can see here that even within MET ALD, it's a spectrum. So, those who may have more alcohol consumption may fit more so on the ALD predominant side towards the right-hand side, versus those who may have less alcohol intake that may be more driven by metabolic syndrome and maybe more MASH, MASLD predominant. And then on the right side, just briefly, I won't be discussing these today, but there are other reasons for steatotic liver disease, such as drug-induced liver injury or, cryptogenic steatotic liver disease. So going through the diagnosis, just to break it down, it's simply that, a diagnosis of metabolic syndrome, which can be done with just diagnosing 1 out of the 5 risk factors on the right-hand side of this slide. So you can see, an elevated BMI, insulin resistance, prediabetes, diabetes, high blood pressure, and dyslipidemia essentially are the factors, in looking at when diagnosing metabolic syndrome. So you can see here this algorithmic approach whereby, once steatotic liver disease is diagnosed just based on imaging, the presence of hepatic steatosis, then, assessing to see if the patients have any cardiometabolic risk factors that would, then lead to the diagnosis of MASH or MASLD. Of course, always asking our patients about, alcohol consumption is key to see, what is playing more of a role. And then, of course, if there are other conditions that are suspected, such as drug-induced liver injury or, some metabolic conditions within the liver, that's something to potentially assess as well. And so briefly touching on epidemiology, this is, the burden of MASH, MASLD globally is going to just increase over time. And what I really liked about this graph is that, we often talk that, at least a quarter of our population in the United States has MASH or MASLD. But, even looking globally, the rates are much, much higher. So in particular, looking at the Persian Gulf, so countries such as Iran, Iraq, Egypt, Kuwait, and Qatar, are countries that have a very high incidence of MASH and MASLD. And of course, Central America, South America have much higher rates as well. And so I think, living in Southern California, where we have such a diverse population of patients, we're seeing this quite often. And, there's a lot of factors that go into it, genetic predisposition, and also lifestyle behaviors. So moving on to fibrosis assessment. So this is an algorithm that was published by AASLD on the heels of a previously published one with the joint between AASLD and the Endocrine Society, which basically highlights the assessment of doing some sort of primary risk assessment in patients who are followed in the primary care or non-GI hepatology setting. And the first test that is recommended to perform is the FIB-4. And a main reason for that is just because those parameters are readily available. So ALT, AST, age, and platelets are what make up the score. And so, since many of those patients that are coming through, if they do have hepatic steatosis on imaging of some sort, should have a FIB-4 done at that point. So less than 1.3 is considered to be low risk. Between 1.3 and 2.67 is considered indeterminate. And then greater than 2.67 is high risk for advanced fibrosis of the liver. So if patients fall into the indeterminate or high risk categories, a secondary risk assessment should be done. And at that point, it's very appropriate to send to one of us to GI or hepatology to assess that with a secondary exam. So I'll discuss some of the options there as well. And then also, of course, even though I have said that we're moving away from liver biopsy, there are still some indications for biopsy if you suspect another concomitant liver disease such as autoimmune hepatitis. And so here I have 3 of the more commonly used lab-based non-invasive liver disease assessments, which are called NILDAs, to estimate fibrosis. So FIB-4, you can see, is readily available, just based on basic labs and demographic information. It's also the most validated. So as mentioned, it's usually the starting point for many of our algorithms when considering fibrosis risk assessment. Then we have the NAFLD score, which again uses demographic and laboratory parameters to calculate. And then APRI, which is basically the AST platelet ratio that can also be used to estimate the risk of probability of advanced fibrosis or higher. So there are proprietary blood-based markers that are available as well. And so I'm going to just highlight ELF just because that's something that AASLD has also done for MASH MASLD. And so the enhanced liver fibrosis test is a blood-based test that measures basically the collagen matrix. So these 3 components, and a score of 9.8 or higher is considered to be high risk for at least advanced fibrosis, progression to cirrhosis, and then other liver-related events potentially. It is approved in the United States and is approved through many different labs as well. And it's good to use in conjunction with other tests. I'd like to highlight that in particular, if elastography is not available, this ELF test is a good alternative. That's something that AASLD says as well. And so basically, in this systematic review and just identifying what the appropriate cutoffs were, 9.8 was considered to be the one that optimized both sensitivity and specificity of predicting advanced fibrosis or higher in these patients. So moving on to, just an algorithmic approach to this. So, as mentioned before, those patients that are very low risk for advanced fibrosis on the left-hand side in the green would be those patients, if we're talking about our MASH MASLD patients, those patients with a FIB-4 of less than 1.3 or a NAFLD fibrosis score of less than negative 1.455. Indeterminate in the middle is that FIB-4 between 1.3 and 2.67. And then on the right-hand side are those patients that are high risk of advanced fibrosis. So those patients that have FIB-4 of greater than 2.67. One thing to highlight is that even though these lab-based NILDAs are available, they should not necessarily be used to monitor risk of progression. And they also cannot diagnose this presence of steatosis. That should really be done with imaging. And so moving on to imaging-based non-invasive liver disease assessment. So I would say transient elastography is probably the most commonly used and the most commonly known. It's usually available in many different places, low cost, it's very well validated. And the failure rate is relatively low, but the reasons for failure would include an elevated BMI or the presence of ascites. There's some other factors as well, but those are the two to consider. And then this shear wave elastography, which is just an add-on that can be done for an ultrasound machine, and just requires like an addition hardware software for that. And there's moderate availability of it. It is low cost because many people do have ultrasound available to them, and high BMI is often a reason for failure of this exam. And then last is MR elastography, which I would say is the most accurate of the three. It's not really widely available and the cost is very high, but it is really good, especially in patients where you consider stage 2 fibrosis or higher. And I'll show you a slide as well, which shows how, its assessment of the entire liver parenchyma is very important, because many of these other tests are just looking at one particular area of the liver, and the MRE gives you a more holistic approach to that. The failure rate is very low. And reasons that this test may not be the best is if there is liver iron deposition present, large ascites, high BMI, and so those are potential reasons for failure. So going to FibroScan, which, as I mentioned, is the most commonly known, most readily available. So they can basically use M mode of the ultrasound to track the propagation of an elastic wave that's produced by mechanical vibration. And so the liver stiffness measurement ranges from 2.5 to 75 kilopascals. And the faster the shear wave propagates, the higher the liver stiffness measurement is, and therefore the higher degree of fibrosis there is in that patient. At least 10 measurements are required with an interquartile range of less than 30% in order to produce a reliable result. And so, as I mentioned, this is, widely available in many different locations and easy to perform, easy to train and easy to perform. So going on to MR elastography. So as I mentioned, it's an imaging technique. That basically using mechanical shear waves, and then also putting a passive driver on the right upper quadrant leads to, obtaining liver stiffness measurements. And the reason, as I mentioned, that it's good and more of a holistic approach to the liver is because fibrosis can be patchy in patients. And so if you obtain, a FibroScan or even a liver biopsy, you may just be assessing that one part of the liver parenchyma. And so by having a view of the entire liver, you can assess and see what degrees of fibrosis may be in which parts of the liver. So this is a good test if available and if indicated. And so moving on to management of MASLD. So I would say that the backbone of MASLD treatment is lifestyle modifications. So a healthy diet and exercise, and usually in an effort to lose weight. We just recently heard a lecture from a clinical nutrition physician who was saying that, regardless of GLP-1s, regardless of bariatric surgery, if these modifications are not implemented, patients will go on to gain weight in the future. And so, I think this is something to highlight and something that we all probably could improve on when counseling patients. And so weight loss of even as little as 3% of body weight can lead to improvement in hepatic steatosis, but the most benefit is when it is greater than 10%. And that can improve both the steatohepatitis component as well as lead to fibrosis regression. And so in counseling on diet and exercise, I think many of us often say the Mediterranean diet, just because it encompasses many of the foods that are considered to be healthy, not only for the liver, but also from a cardiovascular standpoint. And so, just emphasizing a low carbohydrate diet, lean protein, and then just in an effort to lose weight, sometimes patients may benefit from intermittent fasting. 2 to 3 cups of black coffee has also been shown to be beneficial for a fatty liver. And then things that are considered bad would be, excess caloric intake, saturated fats, high fructose corn syrup. And so these are some things to, counsel patients on. One thing I would say, again, as I had mentioned, in Southern California, we have such a diverse population. And so I think at times it is very important to be culturally sensitive, in certain patient populations that may not be able to adapt to a Mediterranean diet. And so breaking it down and seeing some changes that they might be able to make is more beneficial for them. And then, of course, adequate control of comorbid metabolic conditions. So, this is, having good control of diabetes, hypertension, hyperlipidemia. And this is not only to help from a MASH-MASLD perspective, but also to help with the cardiovascular related events that can occur, the morbidity and mortality of metabolic syndrome. And so moving on to therapies. So this is a very exciting time because we have 2 FDA approved therapies. So the first one that was approved in March of 2024 was Rezdiffra or resmetirom. This is a selective thyroid hormone receptor beta agonist. And on the package insert, used in conjunction with diet and exercise, is used for the treatment of non-cirrhotic MASH with F2 to F3 fibrosis. And then on the right-hand side is Wegovy or semaglutide, which was approved in August of 2025. It is a GLP-1 receptor agonist, and also in conjunction with reduced caloric intake and increased physical exercise can be used for the treatment of non-cirrhotic MASH with stage 2 to 3 fibrosis in adults. So you can see very, very similar indications here, and at times can be used in conjunction as well. So going through the 2 trial designs, so the first one for resmetirom for Maestro-NASH, this was a randomized double-blind placebo-controlled trial of a phase 3 data that was published after obtaining week 52 results. And so essentially these were patients that met criteria for MASH-MASLD. They also had to have a baseline liver biopsy that confirmed that, and patients with ideally stage 2 to 3 fibrosis and evidence of hepatic steatosis as well. Patients were randomized 1:1 to 80 milligrams of resmetirom, 100 milligrams, and then placebo. And in terms of their primary endpoints, so they had a dual endpoint of NASH resolution at week 52 without worsening of fibrosis and reduction of fibrosis of at least 1 stage without worsening of steatohepatitis. There's also some composite outcomes that are being looked at at 54 months, mainly cirrhosis and liver decompensation, need for liver transplant, all-cause mortality. Oh, sorry. So baseline characteristics, just what I want to highlight here is that, of course, with MASH-MASLD, most of these patients did have some component of metabolic syndrome. So, most of the patients had diabetes, hypertension, dyslipidemia. And then you can also see about 20 to 25% of the patients were of Hispanic ethnicity. You can see here that in terms of the mean FibroScan liver stiffness measurements, it ranged around 13 to 14. And then on the baseline biopsy, most of the patients had stage 2 or 3 fibrosis, but most of them did actually end up having stage 3 fibrosis. And so with their phase 3 results, which were published in 2024, both primary endpoints were met. So you can see here, as compared to placebo, both the 80 milligram and 100 milligram did show statistically significant improvement in NASH resolution without worsening of fibrosis, as well as a reduction of fibrosis of at least 1 stage without worsening of steatohepatitis. The other thing that was noted as well was that there was a decrease in LDL that was noted at week 24. So just in terms of the adverse events for this medication, so most commonly diarrhea and nausea occurred. So I apologize because these are a little small, but just so you are aware. And then events that actually led to discontinuation before the end of the week 52 data was about 2% in the 80 milligram group, and then about 7% in the 100 milligram group versus 2% in placebo. So going to the ESSENCE trial, which is what led to the approval of Wegovy for the treatment of non-cirrhotic MASH with stage 2 to 3 fibrosis. This was also randomized. It was a multi-center, double-blind, placebo-controlled trial, phase 3 results. And they published week 72 data. So, similar to Rezdiffra, these were patients with MASH on liver biopsy with stage 2 to 3 fibrosis. And in an effort to increase the likelihood that they would have histologic confirmation of MASH with fibrosis, non-invasive tests were also performed, such as ELF, FibroScan, and then MRE as well. And these patients were randomized 2-to-1 to once weekly semaglutide, 2.4 milligrams, which was up titrated over time versus placebo. And their primary endpoints as well included resolution of NASH without worsening of fibrosis, as well as a reduction in fibrosis of at least one stage without worsening of steatohepatitis. There were also some secondary endpoints that were noted, so change in body weight, of course, and then also some quality of life measurements on the SF-36. And so the baseline characteristics here you can see, so a little less than 20% of the patients were of Hispanic ethnicity. You can see that they had elevated BMI as well. More than 50% of the patients did have diabetes. And then most of their patients also had stage 3 fibrosis as compared to stage 2. And then you can see some of these non-invasive parameters that are noted here as well. And so phase 3 results published in 2025 did show that both of the primary endpoints were met. So you can see here that, semaglutide compared to placebo, both in the resolution of steatohepatitis as well as the improvement in liver fibrosis. This was good and ultimately led to approval of Wegovy for the treatment of stage 2 to 3 fibrosis in patients with MASH. Adverse events, so included mostly GI-related side effects. So again, my apologies since this is a little small, but the most common GI symptoms were nausea, diarrhea, constipation, and vomiting, which did occur in up to a third of the patients here. And then you can see here that the events that led to trial discontinuation are actually relatively low, about 2.6% in the semaglutide arm versus about 3% in placebo. And these patients did have up titration of the semaglutide, so that might have led to the tolerability of the medication as well. So there are many medications that are under investigation for MASH. I will just highlight that, the GLP-1s as well as the GLP-1 combination drugs. Survodutide is a glucagon receptor agonist, as well as GLP-1, as well as tirzepatide, which is a GLP-1 GIP, are currently under investigation for the treatment of non-cirrhotic but fibrotic MASH. And then the FGF21 analogs are also under study right now. So pegozafermin as well as efruxifermin, which may sort of add that anti-fibrotic component as well. So these trials are currently undergoing, they're currently in phase 3 trials. And then here, there's some other medications as well. It's interesting because, even in addition to MASH with fibrosis, many patients or many investigators are also looking at, changes in liver enzymes, changes in just liver fat content. And so you can see here that, there's a unique sets of medications that are currently under investigation. So just to summarize, new nomenclature is now available for us to discuss with our patients, MASH, MASLD, to highlight the role of metabolic syndrome in these patients. There's a high prevalence worldwide. It's projected to increase over time as well. There are both lab-based and imaging-based non-invasive liver disease assessments that are available and are acceptable alternatives to liver biopsy for fibrosis assessment. Should be done in patients that have metabolic risk factors and hepatic steatosis. And in conjunction with diet and exercise, there are now 2 FDA-approved therapies that are available, both resmetirom and semaglutide, and they're both under accelerated approval through the FDA. There are also many drugs that are currently under investigation. So, we will see over time what eventually pans out. So something more to offer our patients. And with that, I conclude. Thank you for your time.
Yeah, great talk, Jasmine. Thank you. It's my great pleasure to introduce our next speaker, Laura Tarot. She does not introduction. She is the chief and professor of GI hepatology at the USC CAC School of Medicine. She is recognized nationally and internationally for her great work on viral hepatitis. And she published almost 300 research papers, review articles, and textbook chapters. She served as the past president for AASLD in 2023. She was the lead author for our ASD 2018 hepatitis B guidelines. Now she's co-author for right now the updated hepatitis B guidelines. So it's very timely. It's just published recently. So she will give a talk on key updates on the ASD guidelines for hepatitis B management. Let's welcome Laura.
So thank you for that lovely introduction. And it's really a great pleasure to be here. I agree. It's perfect timing in terms of doing the update on HBV treatment since the guidelines just came out. These are my disclosures, which are not really relevant to the guidelines, but I am going to be at the very end touching base on some recent phase 3 data. So these are my disclosures. So to remind you that the core concepts in terms of treating individuals with chronic hepatitis B have not changed, but have expanded slightly. And by that, I mean, the focus has always been on how do we initiate treatment with the goal of preventing complications, cirrhosis, liver cancer, liver-related death. We've also been focused on preventing vertical transmission. We've always had in place guidelines of preventing mother-to-child transmission. In the new guidelines, what I'm going to speak about is now we're focused also on horizontal transmission as an important goal of antiviral therapy. And then obviously, along with that, we want to think about how do we improve patient outcomes? How do we reduce stigma? And those things influenced the 2026 guidelines. So you know that we have currently 3 very safe, highly effective antivirals available, entecavir and 2 forms of tenofovir. They are the same in terms of their ability to suppress HBV DNA, and they're very broadly applicable across a range of patients. There's really not a patient you can't treat should you choose to do so because the drugs have such great safety profile. Now we choose tenofovir alafenamide over TDF in certain situations where we're trying to minimize effects on bone and kidney, but otherwise, really, this is a great space where we've had highly effective therapies for more than 2 decades. So what can I start to set the stage for 2026 is that first and foremost, I think you'll see that the treatment indications have expanded. We did not embrace a treat all approach, which has been put forward by some, but really stuck with the data. But you'll see that we really gave a lot more flexibility in the guidelines in terms of how to think about treatment. There's also a greater emphasis on shared decision-making, where you really think about the person in front of you, what are their preferences, what are their risks, what are their individual goals, and use that in making your decisions about risks and benefits of treatment. We still talk about phases of infection. You're going to hear me refer to immune tolerant phase and immune active phase. We still think those are important. We still think e-antigen status can help you in deciding about treatment of patients. And the other thing I'll emphasize is that, this is a very dynamic disease. It changes over time. So the decision you make today with your patient may not be the same decision to be made a year from now, 2 years from now, et cetera. And part of that is to always be thinking about what's changing about the patient, including their fibrosis severity, because fibrosis is an important indicator for treatment. All right, so let me just start by outlining the key things that you need to think about when you have the patient in front of you. I mentioned already that fibrosis is important. The guidelines already state that if you have somebody with cirrhosis, they should all be on treatment. End of story. There's no additional considerations. But for those that have F2, based on your non-invasive test, you heard a little bit about that in the Mazel talk, but it's relevant to HBV as well. If you have elastography with a score over 8, if you have an APRI score that's over 0.5, that's very low. Any of those things would be reasons to think about doing treatment. The idea is that once somebody has fibrosis, we are have a lower threshold to initiate treatment. So that's the first. The second, of course, is that they have to be viremic, and we look for evidence that they have active disease, inflammation, which is a driver of fibrosis. The guidelines still use certain thresholds. HBV DNA levels greater than 2,000 if they're e-antigen negative, greater than 20,000 if they're e-antigen positive, and use ALT levels greater than 2 times upper limit of normal, remembering that normal for a woman is 25 and ALT, and for men 30. So a woman who has an ALT level of 55, even if the lab says that's a normal and your normal range for your lab, that is abnormal for a Hep B patient and would qualify for treatment. And then the other thing is to think about other cofactors that we now understand are drivers of risk for liver cancer. And those become reasons for us to think about treatment to suppress virus. So at least we take that out of the equation. So that's the patient with HIV, Delta, hepatitis C, anybody with a family history of liver cancer, cirrhosis, anybody who's immune compromised. And then I'm going to talk more about this risk of transmission to others. So the AASLD guidelines in 2026 is a little bit different than the 2018, which covered every topic under the sun, really related to hepatitis B. The 2026 guideline says we're just going to focus on key areas that we think the data has emerged that would allow us to update the recommendations. So I'm going to cover these 5 areas, which are really where there's change. Everything else about Hep B has really remained the same, but these are the areas where there's a nuance that you need to be aware of. The first being mother-to-child transmission. So for women who are pregnant, it's all recommended to be tested for hepatitis C using the triplet. And by that, I mean hepatitis B surface antigen, anti-HB core, and anti-HBs. If they lack all markers, they should be vaccinated. You can vaccinate in pregnancy without any concerns. But if their surface antigen is positive, then you need to get a viral load. And if their viral load is greater than 200,000, this woman should be offered treatment in the 2nd to 3rd trimester to minimize the risk of mother-to-child transmission. What's changed in this guidelines is we've added that TAF is now safe. Before it was only TDF was recognized as having a sufficient safety record. Now we have good data that says TAF is also safe. So TDF or TAF are your preferred therapies. If you have a woman who's on entecavir and then presents pregnant, you need to change her over to a tenofovir-based therapy. The other changes in the recommendations that were made is we're actually recommending you start earlier. The recommendation is now you should start at week 28, not 28 to 32, which is what we used to say. Now we say 28. And if the woman is going to potentially get invasive procedures like an amniocentesis or something, they're a high-risk pregnancy, you should start their treatment basically as soon as you find they're pregnant, because they may need to have their virus suppressed earlier in pregnancy. Then at the time of delivery, you can stop the antiviral. If you're only using it to prevent mother-to-child transmission, your work is done. And at the time of delivery, after the delivery, you can stop the drug. And that sort of facilitates, the aspect of concerns around being on drug while breastfeeding. Infants should all get HBIG and their first dose of vaccination, and then of course complete the vaccination thereafter. Now, if you have a woman who has chronic hepatitis B and they need to stay on treatment for usual indications because they have active disease, then of course you should continue it postpartum, and there is safety data to say that tenofovir is safe for breastfeeding. Okay, so that's pregnancy. The second area that we discussed and has changed, I think, quite dramatically is immune tolerant hepatitis B. So just to remind you, and this is one of the things that we did very carefully in the guidelines, is we strictly define what is an immune tolerant adult. Remember, that's sort of the first phase of chronic hepatitis B infection. It's where the patient is E antigen positive. They have very high levels of virus, and we define that here as being over 10 to the 7th IUs per ml, more than 10 million. And a normal ALT, again defined by ALTs of 30, 35, and 25 for women. So in 2018, we actually said these individuals should not be treated. We were actually firm about that. We actually said there's no data to suggest benefit. So you'll see now that in 2026, we've changed. First of all, now we bring age into the equation. If they're over the age of 40, you should treat them, regardless of anything else. And then of those under 40, then we say that's where you should use this shared decision-making approach. If the patient's interested in being treated, if you feel they should be treated, you can treat them. You should definitely treat them if they have a positive family history, and you should always, of course, look at their fibrosis. And if there's any evidence of fibrosis that's F2 or higher, you should treat. So a very different change. Now we really are moving towards this immune tolerant treatment. Now, why do we sort of very specifically define immune tolerant? I'm just going to show you one slide to highlight that it really is this immune tolerant is this group that's got a very high viral load. And you can see on the left, this is a very nice study that looks at the HBV DNA level and then risk of cancer. And what you'll see is that there's a very low risk of cancer in the group that's immune tolerant, that has a viral load of 8 log or higher, actually 7 or higher in this figure. Whereas those that have lower viral loads, then your risk for liver cancer goes up. So when you have an E antigen positive patient, and they look like they're immune tolerant, but their viral load is under 10 to the 7th, that patient is no longer immune tolerant. They're moving into an at-risk group, and we now recommend those people should be treated. And another clue is that you should really characterize their fibrosis very carefully. FIB4 is very good in this setting. And in this study, if you have a FIB4 that's under 1.45, you can see the risk for cancer is essentially negligible. So use FIB4, use that viral load to really define the group that's immune tolerant. And if they're really truly immune tolerant, you can actually defer treatment. But if they're over 40 and have anything that suggests they're sort of moving into a next phase, you should treat. So this kind of gets at this sort of indeterminate phase when people are transitioning. And so again, the guidelines made a change here for this as well. In 2018, we recommend that if you have a person who's in the indeterminate phase, and what is indeterminate? It's where their ALT doesn't quite meet the criteria, or their ALT or their HBV DNA level isn't quite high enough. They seem like they're in between. In the past, we used to say that you should just follow them, and eventually they're going to declare themselves. They're either going to have their ALT go up high enough, you'll say, okay, now I can treat, or they're going to normalize and you're going to say they're inactive and I don't need to treat. We used to say just monitor, they'll declare themselves. But in 2026, we now have had a lot of studies that have come out that say that actually we're not very good at sort of seeing people evolve, and we are missing opportunities to intervene at the right time. And for that reason, the recommendation for patients in the indeterminate phase changed in 2026. Again, we say that if they're advanced fibrosis, treat. But even if they don't have advanced fibrosis, we now say consider antiviral therapy, which really means treat. Of course, do it in a shared decision-making kind of approach. There's still going to be patients in which you're going to choose to monitor, but now we have much more flexibility about treating these indeterminate patients. Just a little bit about how common this is. And I think this is what sort of inspired us to make a change really with the guidance. This is data from a study that includes patients from California and Taiwan. It's a large retrospective study, almost over 3,500 patients. And these are patients that are presenting at the first visit. They don't have cirrhosis. They don't have an indication for treatment. And then what they did in this study is they said, well, how many of them kind of meet the classic definition of immune active and should be treated? That's the shown here. Which ones are immune tolerant, don't need treatment, et cetera. Then they said, how many are indeterminate? It turns out it's 40% of patients fall into the indeterminate bucket. And then when they followed them for up to 5 years, 75% of them were still indeterminate, right? So that's why we sort of recognize that indeterminate is like really a phase. It's not just a sort of an in-between thing, but that in-between thing has meaning and it can be associated with outcomes. And so therefore we recommended treatment. So one study I just want to say, but this is still controversial, and just to say that you can still choose not to treat these patients. We recommend a shared decision-making. You should think about that when you're, does the patient, can they commit to being adherent to treatment forever? That kind of idea. But just to say, this is a very recent study, just came out, highlighting that, really we still are gathering data about this. So it's a very large study from Hong Kong, more than 17,000 patients that are in this indeterminate phase. What the graph on the right shows you is two types of indeterminates, one where the ALT is normal, but the HBV DNA is high. That's one kind of indeterminate. And then the other is where the ALT is abnormal, but the HBV DNA is low. That's another indeterminate type. But what's important about this study is they compared those that remained off treatment versus on treatment. And what they showed is that treatment doesn't make a difference in terms of their risk for HCC in this case. So it's these data and others that still allow you as a physician with your patient to make a decision that you're just going to do close monitoring rather than initiating treatment. But the guideline now is much more flexible that if you choose to treat, it's also supported. So just to kind of summarize this indeterminate group, whether you're e antigen positive or e antigen negative, you don't quite fall into the buckets, right, of having an HBV DNA level that meets the threshold or an ALT level that's 2 times upper limit of normal, that now you're in a position where you can consider treatment of that individual. The things that we think should strongly encourage you to think about treatment is, of course, the fibrosis, but also age. Generally, individuals after the age of 40, especially for men over 40, women over 50, their risk for HCC is going up. So generally, we're much more in favor of doing treatment in that setting. And males always have higher risk for HCC than females. So those things may influence your decision about my patient with indeterminate in the indeterminate phase, whether I'm going to start them on treatment or not. And why does the sort of decision about treatment start matter? Well, that leads us to thinking about sort of when we're going to stop, and I'll get to that in a second. So the other area that is new to the guidance is about treating solely for the reason of preventing transmission to others. We talked about it in the mother to child transmission, that's well established. But aside from that, we didn't have a strong recommendation before about what you should do with a patient who's got a virus that's circulating, but doesn't have an indication for treatment. And that's especially those immune tolerant patients, right? Who have very high levels of virus, but don't really have disease. Their ALTs are normal, their FIB4s are normal, their FibroScans are normal. Those individuals, we now are saying, think about treatment in them. But one of the reasons to think about treatment in those individuals is, do I have to think about trying to prevent them from transmitting virus to others? This requires you to really do a deeper dive into the individual's history, find out about what their sort of social situations are to determine if this is a reason to consider treatment. So while vaccination still remains the main way we protect individuals who are around an individual who's infected, so their sex partners, their family members, their people in the household, recommendation for somebody who's viremic is get everybody else vaccinated. That remains. But there are situations in which transmission may occur outside of that, and you may decide you want to treat a patient solely just to prevent transmission. And some individual patients are very worried about transmitting to others, and you have to listen to that, and you should think about treating them solely to help them with that aspect. So what are the situations in which you should really explore with the patient whether they warrant treatment solely for prevention of transmission? Well, if you happen to have somebody who's in a household where maybe they have immune compromised individuals, where people have been vaccinated but didn't respond, so they really have susceptible household members, that's a scenario in which the person who's infected should be treated. Anybody who's involved with injection drug use or other at-risk drug behaviors where they're not consistently using harm reduction, they should be on treatment. Anybody who's engaged in unprotected sex or has multiple sex partners should be treated. And then, of course, healthcare personnel, you're all very familiar with how we treat those individuals to prevent transmission to patients. So those are scenarios you now need to consider. And then the final area that the guideline changed in 2026 is around withdrawal of treatment. So it's the final area. In 2018, we actually said that you can consider stopping treatment in selected individuals who'd been on suppressive therapy for at least 3 years and had low levels of surface antigen and who had a desire to stop treatment. And you could do it with close monitoring. But in 2026, we have changed. And we've changed primarily because the actual benefits of coming off treatment seem to be quite modest in terms of many have to go back on treatment. The rate of losing surface antigen which was part of the reason why this became very popular, is actually quite low. And there's really a kind of a hazard in taking people off treatment in terms of them getting ALT flares and potentially even experiencing liver decompensation. So for all of those reasons, now in 2026, we say you should not stop treatment. Once you start someone on treatment, you should treat them until they lose surface antigen, functional cure. The only exception to that rule is the patient that you're putting on treatment for prevention of transmission, where you may stop treatment once their risk for transmission goes away, right? But everybody else, once you start, you are treating really forever, right? Not forever, but long-term. The idea is no withdrawing. That is not a recommended practice anymore. So really, if your patient is really pressing you to say, I really want to come off treatment, you should say, the guidelines now are saying really the risk is higher than benefit here. You should stay on treatment until you lose surface antigen. All right, so this is kind of the summary of the changes that have occurred in the guideline. So we now have expanded indications. Some of these were there before. So before, we always said advanced fibrosis, cirrhosis, treat. Anybody with active chronic hepatitis B, as defined here, treat. Now we're saying immune tolerant over 40, treat. And of course, we say all special populations, they need to be considered. But the ones that are in the right are the shared decision-making group, where treatment is certainly something you can consider. Feel free to discuss it with your patient. It's your immune tolerant patient under age 40. Those in the indeterminate phase, and I think really the emphasis is on try to consider treatment more strongly. And then, of course, those where you're trying to prevent horizontal transmission. So the umbrella of things in which you can consider treatment have certainly expanded. And my kind of response to any physician who asks me is that basically any patient who's viremic is eligible. And if you choose to make the decision to start that patient on treatment. That is perfectly acceptable, but know that you're committing them to treatment till they lose surface antigen. So I'm going to end with just giving you a little flavor of that future, right? So when we say that you have to stay on treatment until you get surface antigen loss, that's kind of where we are with our current suppressive therapy. But we know that the rate of functional cure or surface antigen loss right now with our current NAs is about 1% per year. So most patients are going to be on treatment really their lifetime. But we're very, very interested in the new drugs that are coming down the pipeline, which are focused on giving a finite course of treatment and getting more patients to lose surface antigen over shorter periods of time. And I'll just show you one study, and I show you this one because it is the furthest along in development. And at the recent EASL meeting, the phase 3 study was presented. So we can anticipate that this drug is likely to move forward for FDA approval. So this is bepirovirsen, which is an antisense oligonucleotide. This drug really prevents the translation of all of the proteins related to hepatitis B, and also has immune modulatory effects as well. In this study, what was done is in this very large phase 3 study called B1 and B2, B-Well 1 and 2, which were conducted globally. Every patients with chronic hepatitis B without cirrhosis who were on nuke therapy and had a HBV DNA level under 90 were eligible if their surface antigen level was between 100 and 3,000. And you might ask, well, why was that selected? It was based on their phase 3 data their phase 2 data in which they showed that was sort of the sweet spot for getting high rates of surface antigen loss. So in this large study, patients who were on NAs were randomized to getting 24 weeks of bepirovirsen or placebo. Shown on the right is the rates of functional cure. So now what happens is they take the bepirovirsen and then they're treated for NUCs for another 24 weeks, and then all treatment is stopped. So, and then they evaluate them 24 weeks after they've stopped all treatment, and that's your definition of functional cure. So what you can see is in the study, about 20% of patients achieve functional cure. Off all treatment, 24 weeks off all treatment, 20%. And if you looked at the patients that had a surface antigen levels under 1,000, that number goes up to almost 30%, 26%. And that was, of course, higher than placebo, because I just finished telling you that when you're on a nuke, your rate of losing surface antigen is about 1% per year. So it was 0 here. So this now tells us that we're entering a new phase, right? Where now we can say to a patient that's on nuke and has been on for many years, if we do 24 weeks of a specific treatment like bepirovirsen, we may see 1 in 5 or 1 in 4 individuals achieve functional cure and be off all treatment. So that's our future. The adverse events here, I'll highlight their ALT elevations occurred in about 20% of patients. They happened during the bepirovirsen phase, but they were not complicated. And there's injection site reactions. This drug is given by subcutaneous injection. They get 2 injections in the first week and then weekly for the 24 weeks. So just to say it's coming. This is our future. And I think it gives us hope that these patients that we're putting on nukes and we're saying to them, you have to stay on until you lose surface antigen, that indeed more of them will lose surface antigen in the future as we kind of move towards this new era of HBV therapy. But one of the things I'll highlight by the study is that, many of us are not measuring surface antigen quant. It's available to you. You can get it through the commercial labs. And I would encourage you and your patients on nuke to start obtaining this. In my practice, I do it every year. I get their surface antigen quant, so I sort of know where they're at. Because as we move to this new era of therapies, that level is going to influence whether those treatments are eligible to them. So my key takeaways regarding the HBV treatment in 2026, I'll start with, in principle, any viremic patient can be considered for treatment. You are the physician, the patient's in front of you. That is your decision. The guideline indications for treatment have expanded. I've tried to share with you that now we have a much more expanded portfolio for recommended treatment. Shared decision-making is increasingly emphasized, where you really have to understand the personal preferences of your patients and their own risks and benefits. For some patients, the co-pays of the drug and the burden of taking a pill every day really are important and may lead you to choose not to treat in a particular instance. So you have to have those discussions. Regularly assess the fibrosis severity since it's a clear indicator for treatment. And once you start treatment, you treat to surface antigen loss. And I'd encourage you to start measuring quantitative surface antigen as part of your management of patients on NUC so that you can kind of get a sense of when they might be losing their surface antigen. And then finally, anticipate future finite therapies that are going to be focused on functional cure, where quant's going to be one of the primary determinants of eligibility. Thank you very much.
Great talk. Thanks, Nora. My pleasure to introduce our next speaker, Dr. Brian Lee. Is an associate professor of medicine and a transplant hepatologist at USC Keck School of Medicine. His research focuses on alcoholic liver disease and muscle D. He needs a very big research project called Accelerate, sponsored by NIH. It's a research consortium, and he has a publication on top journal like Lancet and Annals of Internal Medicine. He actually gave the same talk in last year, a post-ASD, postgraduate course. It was highly appreciated. I think it's a very timely topic. I think we miss a lot of MAD ALD, muscle D patients. So he will give us an excellent talk, right?
Well, thank you, Dr. Hu, and for the organizers for having me. This has really been an enormous amount of interest and data published on MET ALD. So I'm happy to be here to share this. So these are my disclosures. So really how I've framed this talk is to first establish a framework and convince you why MET ALD is a distinct disease entity with dual driver of outcomes. Two is to talk about how to treat this, and how I've centered this is on a two-pillar approach. And finally, end with emerging therapies. So even though patients with MET ALD have always existed in our clinic, it's only been officially named since 2023. And here it is. It's metabolic dysfunction associated steatotic liver disease with increased alcohol consumption. To have MET ALD, you need one of each of these three columns. In the first column, you need to have steatosis, either on imaging. You can have the absence of steatosis if you have advanced fibrosis. This is an acknowledgement that in advanced disease, steatosis can burn out. In the middle, you need one of at least one metabolic risk factor, being overweight, dysglycemia, hypertension, or dyslipidemia. And finally, you need increased alcohol consumption. So there are different stratifications for women and men. Women are at higher risk for developing liver disease at lower quantities of alcohol consumption. For this, we describe it as 140 to 350 grams per week for women, 210 or 420 grams per week for men. One drink is 14 grams of alcohol. So if a woman drinks 1.5 drinks per day, or if a man drinks 2 drinks per day, that's considered in this MET ALD stratification. So when is it justified to name a new subpopulation of a disease? I would say that this is the framework that I would use. One, we can tell the difference, that we have diagnostic tests and that we have a clear definition. And two, that we care about the difference, that the disease behaves differently, that it changes our patient management, and that it can influence health policy differently. In sum, MET ALD is a justified subpopulation if we can identify the individuals. And two, it would be valuable to separate them in clinical settings and research. So, is MET ALD justified? This is a prospective study from a large Danish population. And this is a Kaplan-Meier curve showing you the probability of without hepatic decompensation. On the x-axis, you have time in months. In red, you have patients with no SLD. In green, MASLD. Then in blue, MET ALD. Then in purple, ALD. You can see here that MET ALD has worse outcomes than MASLD, but better than ALD. So I would say that MET ALD has a specific phenotype that behaves differently. So we should care about separating it for clinical research and interventions. So if we look at the old nomenclature here, we had NAFLD and ALD. And at the top, you see increasing quantities of alcohol use. The consensus nomenclature you see that Met ALD is in fact a subpopulation of old ALD. In fact, patients with ALD, even with the new consensus nomenclature, 90% of patients with alcohol-associated liver disease have one or more metabolic risk factor. We also showed that 99% of people with the old NAFLD definition meet the MASLD definition. So essentially, NAFLD and MASLD are interchangeable. So the take-home points here are that Met ALD is distinguished from ALD due to lower alcohol use, not by the presence of metabolic risk factors. And that two, Met ALD is a new subpopulation reclassified from old ALD. So in these patients with Met ALD, outcomes are driven by both alcohol and metabolic risk factors, requiring this dual pillar approach to treatment. So the question is, well, if patients with ALD have metabolic risk factors, why don't we call them also Met ALD? So this is a nice study from the UK Biobank, which looked at 300,000 patients with over 12 years of follow-up. Their outcomes were incidence of cirrhosis, liver decompensation, and liver cancer. On the right panel, you can see their results. They stratify patients by MASLD, Met ALD, or ALD levels of drinking. And then they looked at each metabolic risk factor in association with the outcome. You can see at the bottom row for each panel, you have the composite burden of cardiometabolic risk factors, ranging 0 to 5 for number of metabolic risk factors. You can see for MASLD and Met ALD, cardiometabolic burden was highly associated with liver-related events, over 5-fold higher risk of liver-related events. But on the bottom, you see alcohol-associated liver disease. Cardiometabolic burden was not associated with increased risk of liver-related events. So the take-home message here is that metabolic risk factors are associated with liver-related events at MASLD and Met ALD alcohol ranges of drinking, but not at the alcohol range of drinking. So how do we treat patients with Met ALD? I would advocate that you really need this two-pillar approach. If you only treat one pillar, then you're leaving behind residual risk. So we'll go through these one by one, starting with alcohol reduction and then treating cardiometabolic risk. So what is the rationale for treating alcohol use? And I'll make a controversial statement in that in a patient with Met ALD is that alcohol is likely the dominant driver of liver-related outcomes, despite metabolic risk. So this is a nice study from Spain, looking at 6,800 patients who were recruited prospectively with transient elastography. And then they validated their results using the NHANES survey in the United States. So here on the y-axis, you see the number of metabolic risk factors. And on the x-axis, you have increasing levels of alcohol consumption. Here, you only have patients with MASLD and Met ALD. So the first three columns are all within the MASLD range. Each box then represents the prevalence of significant liver fibrosis by transient elastography. Now, I'll draw your attention to the first box here, the reference group. With one metabolic risk factor in 0 to 4 drinks per day, you get a 2.2% prevalence of significant liver fibrosis. In the same level of drinking, but if you had 4 to 5 metabolic risk factors, your prevalence of significant liver fibrosis increased to 9.5%. If you increase your alcohol consumption to 10 to 13 drinks per week, or 10 to 20 drinks per week for men, still within the MASLD range, you can see that the prevalence of significant liver fibrosis was 12.8%, higher than having 4 to 5 metabolic risk factors. If you entered the Met ALD range of drinking, you can see with just one metabolic risk factor, your prevalence of significant liver fibrosis was 16.7%, almost double what it is for 4 to 5 metabolic risk factors with 0 to 4 drinks per week. So the take-home message here is that the influence of alcohol likely dominates in Met ALD and can even dominate with MASLD. Now, we published an NHANES study that was nationally representative, looking at patients with MASLD. There were 2,300 patients with transient elastography. We found that 67% of patients with MASLD reported alcohol use in the last 12 months. The outcome here was advanced liver fibrosis by transient elastography. Our results were that the risk of advanced liver fibrosis increased amongst men with more than 7 drinks per week. And for women, there was no safe threshold. there was a linear increase in risk of advanced liver fibrosis with any alcohol consumption. So the take-home message here is that alcohol affects the risk of liver fibrosis well within the current masked alcohol range, especially for women, and that alcohol in MET ALD is in fact high. It's a misconception that it's moderate. Now, I'll really represent this message here. So this is looking at the criteria for steatotic liver disease by nomenclature. And in blue, you have men, and in green, you have women. You can see here, this is the NIAAA criteria for heavy drinking. You can see that every patient with MET ALD meets the NIAAA definition for heavy drinking, and even some women in the MASL definition meets the definition for heavy drinking. Also, the nomenclature looks at average alcohol consumption. Most patients do not drink the same amount every day. Some patients, for example, only drink on weekends. So for example here, if you had 5 beers on every Friday, 5 beers on Saturday, that would be 10 drinks per week. You'd still be classified as having MASL. So we looked at this question specifically, and this was led by a medical student at USC. And we looked again at NHANES, and we looked at patients with MASLs, and we found that 16% reported having episodic heavy drinking, defined as 4 or more drinks in women or 5 or more drinks in men, at least once per month in the past 12 months. For reference, 16% of patients with MASLs is more than the entire estimated current MET ALD population. So we found that amongst patients with MASLs, having this episodic heavy drinking had a 2.8-fold higher risk of having advanced liver fibrosis, even after adjusting for average alcohol consumption per week and adjusting for age and sex. You can see here on the figure at the bottom, on the y-axis is the national prevalence, on the x-axis is the different stratifications of SLD. In blue, we have the normal nomenclature, and in green, you have those including with episodic heavy drinking included as a MET ALD or ALD. You can see that the prevalence of MET ALD would increase more than 2-fold if you considered those with episodic heavy drinking as having MET ALD. So the take-home message here is that you should consider patients with episodic heavy drinking to have MET ALD, not MASL. So how do we treat these patients? And this is the stepwise approach that I use to treat alcohol use. So first, I screen all patients for alcohol consumption. And Audit C is the most validated self-report. It takes about 30 seconds, and it's been translated into over 50 languages and only comprises of 3 questions. I supplement this with phosphatidylethanol, which is a blood-based test which detects alcohol consumption in the last 28 days. We've shown that up to 20 to 30% of patients who report no alcohol consumption, in fact, do. Brief intervention for patients who screen positive for heavy drinking. Here, the evidence-based way is to do a brief intervention. And for patients who don't have alcohol use disorder, this alone can be enough to have them stop drinking. If patients continue to have heavy drinking on follow-up, this is when I step up their therapy. We're doing motivational interviewing. We're referring them to addiction specialists, potentially for behavioral therapy, and also referring them to group therapy like AA. Also, if they meet alcohol use disorder criteria by DSM-5, this is where I'm offering them pharmacotherapy. So there are many options for pharmacotherapy to treat alcohol use disorder. What we've done at USC is we've tried to simplify it. So we've trained all our fellows to prescribe alcohol use therapy off of 3 potential medications. So the first here is naltrexone, and this is what has the most data in the general alcohol use disorder population to reduce alcohol consumption. It's an opioid antagonist. It's once daily dosing orally, 50 milligrams. It's FDA approved to treat alcohol use disorder, and it's best used in patients who are actively drinking. Caution here is that it can't be used in patients who are already using opiates, since it is an antagonist. In the middle here, you have patients, you can prescribe them acamprosate. Here I use 999 milligrams twice daily. Again, it's FDA approved to treat alcohol use disorder. It's best used in patients who are already abstinent to maintain abstinence, to prevent future cravings. The caution here is that It's rare, so should be avoided in patients with an eGFR less than 30. Finally, I use gabapentin as well. So here I use 1,200 milligrams per day divided in 3 doses. It's best used in patients who have past withdrawal symptoms. It can also help with sleep and anxiety. It is also renally cleared, so you may need dose reduction in patients with chronic liver disease. And it does have street value and sedating, so you do have to be careful for misuse. In terms of Pillar 2, this is where we treat metabolic risk factors. So the rationale for treating metabolic risk factors is here we published a national study looking at the prevalence of high FIB4 in association with increasing metabolic risk factors. We found that increasing metabolic risk factors was associated with higher risk of having significant liver fibrosis, and we had an optimal cutoff of 3 or more metabolic risk factors amongst heavy drinkers. On the right table here, we showed in a multivariable analysis that in fact, all metabolic risk factors are not equal. High waist circumference, hypertension, and diabetes were associated with increased risk of significant liver fibrosis, but not hypertriglyceridemia or low HDL. So this is an example of the potential effects of treating metabolic risk factors in a patient with MET ALD. So here I've used an example of bariatric surgery, which can potentially treat all metabolic factors simultaneously. So here's a prospective study from France, which recruited patients with biopsy-proven MASH, and 53% had F2 or more fibrosis. 64 patients had serial biopsies at 5 years, and the figure on the right represents their results. So you can see at 5 years, 84% of patients had MASH resolution, 70% had fibrosis regression, and 56% had disappearance of fibrosis. But the caveat here is that metabolic risk factors may have different risk according to the level of alcohol consumption. So this is, again, going back to the UK Biobank, which looked at over 300,000 patients. They looked at the risk factors for developing liver-related events in the MASLD alcohol range here on the left, and on the right, MET ALD alcohol range. You can see that hypertriglyceridemia and hypertension had the least importance in the MASLD alcohol range, whereas being overweight, having low HDL cholesterol, and prediabetes or diabetes had the highest importance. But if you looked at the MET ALD alcohol range, hypertriglyceridemia again had the least importance. But now, having obesity and low HDL cholesterol actually declined in importance, whereas hypertension increased in importance, and diabetes remained the most important factor. So the take-home message here is that the importance of each metabolic risk factor from MASLD cannot necessarily be transported to MET ALD. It may vary at different ranges of alcohol consumption. We also have to acknowledge that the threshold for this, for MET ALD and ALD, are in fact arbitrary in terms of alcohol consumption. So this was a study from Denmark, which looked at the 10 risk of developing cirrhosis amongst 350,000 patients without cirrhosis. And they had 3.3 million person years follow-up. So here on the y-axis, you have increasing risk of developing cirrhosis. On the x-axis, you have increasing levels of alcohol consumption. In each category, you have increasing BMI stratifications. So on the left, in orange dots, you have 10 to 140 grams per week of alcohol consumption. You can see that the risk of developing cirrhosis increases with BMI class. In green, you see 150 to 280 grams per week of alcohol consumption. You can see that the green dots are all higher than the orange dots, but they still within this category, it increases with BMI class. At the highest alcohol consumption, 290 to 420 and over 420 grams per week in green and purple dots, you can see that they're all higher than lower alcohol consumption, but here the BMI strata are the same. Absent for alcohol consumption greater than 290 grams per week. And if we looked at the nomenclature for where the stratifications and thresholds are for alcohol consumption, you can see that the MET ALD threshold is in fact lower than 290 grams per week. So it suggests that the upper threshold to define MET ALD may in fact need to be lower. So I'll end with emerging therapies for MET ALD. And the idea is that the holy grail of MET ALD would be if we could treat both of these with just one drug. So an example of this, in theory, is a GLP-1 receptor agonist. While you have peripheral receptors for GLP-1s, you also have central ones as well. On the peripheral side, it can increase insulin sensitivity, promote weight loss, reduce hepatic ketosis, reduce inflammation. We have shown in clinical trials that GLP-1 receptor agonists reduce steatohepatitis and improve histology in the liver. On the central side, we know that GLP-1s can potentially decrease mesolimbic dopamine, which can reduce cues to alcohol consumption, reduce cravings, which can lead to reduced alcohol intake. This is no longer just theoretic. So hot off the press is truly what is a landmark study published in the Lancet in the last 2 months. So this study looked at 108 patients with alcohol use disorder with comorbid obesity. They looked at patients and randomized them to semaglutide 2.4 milligrams weekly versus placebo. Their primary endpoint was number of heavy drinking days after 26 weeks. You can see on the figure on the right, red semaglutide, blue placebo. They met their primary endpoint. There was a reduction in heavy drinking days, which was confirmed by the biomarker phosphatidylethanol with an absolute 0.28 difference amongst semaglutide versus placebo. The next example is FGF21 analogs. So on the peripheral side, FGF21s have been found to increase lipid oxidation, decrease sensitivity, and decrease stellate cell activation. And this last aspect is particularly interesting for MET ALD and liver disease in general. And you can see in the phase 2B study, looking at non-cirrhotic MASH, that you had reduction in fibrosis in the FGF21 arm. On the central side, you also have decrease in dopamine, but here it's in the nucleus accumbens, which can potentially reduce alcohol intake and desire. So another hot off the press study was a study published in Journal Hepatology last month. So this was a genome-wide association study which combined several biobanks together. They had a Mendelian randomization design looking at the impact of FGF21 on alcohol-related outcomes. So on the right side here, you can see that if you had genetically higher levels of FGF21, you had reductions in problematic alcohol consumption, reductions in alcohol-related liver disease, reductions in acute alcohol intoxication, and reduction in alcohol consumption. The take-home message here is that we do need human trials with FGF21 targeting alcohol consumption. So in conclusion, I hope I've convinced you that MET ALD does have a distinct phenotype where outcomes are influenced both by alcohol and metabolic risk factors, which should prompt you to have a dual-pronged approach to improve clinical outcomes. Hope I've convinced you that drinking levels in MET ALD are not moderate, they're in fact high. Distinguishing alcohol use disorder versus not can inform your patient management. GLP-1 and FGF21 agents are emerging therapies with this potential dual action treatment. And finally, that MET ALD has been historically excluded from clinical trials. And we do need more inclusive trial designs to be able to meet this unmet critical need. That's all I had, but I'd be happy to answer any questions during the panel session.
Okay, thanks, Dr. Lee, for a great talk. So we're moving on next part of hepatology hot topic panel discussion. We'll welcome faculty speaker back. We also have two additional faculty here I want to take a little opportunity to introduce to. Dr. Norman Gitlin is a well-known hepatologist. He was the chief of hepatology, professor of medicine in Emory University before his retirement and moving back to Southern California. He has really extensive research from viral hepatitis to different liver diseases too. He is still a consultant editor for Clinicus in liver disease as a great reference in hepatology field. Dr. Sam is up. He does not need the introduction. I still do a little bit too. So yeah. So he's a professor of hepatology and surgery and the director of Liver Institute at UCLA Health. He has numerous publications, major outcome studies from liver transplant to viral hepatitis to all the fields of hepatology. Is active speakers. Everyone knows him too. So we'll move on. Really welcome for the questions. So we can have questions related to today's topics. Also, any hepatology part. This is a great opportunity. We have a great panel here. Thank you very much. Kevin, first.
Thanks for all the talks. So I have a scenario. It's kind of a case study. 61-year-old guy, history of Crohn's disease on Vito. And they happened about 3 years ago. All of a sudden, he complained of feeling very fatigued, tired. So I did just a panel blood test, came back AST, ALT, all of a sudden in the 500s. And then repeat blood test, a week later, 700s. And basically in a case of acute Hep B. All his blood tests before was negative, and we were able to track it because he was on Vito. So every time he got the infusion, he got blood tested. So now we have a guy with a history of Crohn's disease on Vito with acute Hep B, with rising AST and ALT, and kind of symptomatic in a way. He was started on entecavir, and now surface antigen negative, E antigen positive, Hep B DNA negative, core positive, still on Vito, and most likely he will stay on this course for a while. 3 years gone by, he's still staying on entecavir. So should we keep him on entecavir 0.5 at this point and treat him as, anyone with an acute Hep B and, and basically now surface antigen negative, or we just continue him on the entecavir? And the second question is, should I just continue on, monitor him with ultrasound, every 6 to 12 months too?
This is a great case here. Kevin, I want to be sure. You said lost surface antigen, but E antigen is still positive? That's very, very impossible in general.
Basically, he turned around very quickly after, I would say, 3 to 4 months in terms of his viral load and the rest of the blood tests, ALT is coming down on the treatment. So my fear at that time is, this guy is basically on an immunosuppressed medication, and we decided to treat at that moment.
I turn to the panel.
Can I just ask a clarifying question, though? When patients are put on any immunosuppressive therapies, they get HBV panels done before. So was all of his markers negative before he started Vito?
Yes. It was negative.
He really is a newly acquired Hep B, as opposed to reactivation, which is a little bit what you kind of are hinting at, that maybe this was reactivation, but it's not if he had all of his markers being negative before and then he acquired Hep B.
Yeah, he definitely a newly acquired Hep B. At Kaiser, every year someone on with IBD, he needs, before he got the infusion, the nurses actually check for a yearly blood test. So it's an automatic thing that he actually got checked. And I didn't tell you the whole background. There was whole investigation 1 month prior to this, blood test being positive for acute Hep B. He did have a hernia repair, robotic hernia repair. So that actually led to a whole investigation with the OR and why it happened. And he did travel to Thailand a lot. He's, divorced guy. And I really asked him to the detail. This is the whole detail of the whole background that I got to the bottom of it. And we still don't know why he got acute Hep B.
Oh, I think we do know, but anyway. But I think it's really interesting, actually. Can I just say, this is like a missed opportunity for vaccination, though. Individuals who are going through immune modulatory therapy, the recommendation is that they be vaccinated. So I'm assuming he tried.
He did not want to.
Well, oh my gosh. Okay. Well, he's a problem.
Because he's, with IBD patients, we hold the whole vaccination discussion at the time of treatment as well. And he did not want to at that time. Now he wanted to, but too late.
But has he made antibody?
I'm sorry?
Has he made anti-HBs?
Surface antigen positive, and now...
Oh, he's surface antigen positive. I thought you said he lost surface antigen.
Oh, at that time it was positive, and now it's lost already.
Right. So he lost surface antigen. Has he made anti-HBs?
Yes.
What titer?
I don't have a titer.
So just my take on this is that while his veto probably, had some influence on his ability to recover from acute hepatitis B, he's done very well. He's recovered, right? Mm-hmm. And if he has antibody, and it's a titer that's measurable, and sometimes you actually see even it go up, then I'd be very comfortable stopping his entecavir because he's got protection. But if it's one of those antibodies where it's like hovering around the cutoff and it may disappear, then I'd be a little bit more concerned. So I think it's the kind of patient that I would sort of monitor him on treatment to see what the antibody response is. But I think if he has an antibody, then I would be okay with taking him off entecavir and monitoring his antibody to make sure he continues to preserve it. Because veto isn't really viewed as a drug that's at high risk for reactivation. It's not. And so I'm not sure it had a lot to do with all of this, except that it might have influenced his ability to clear, but he's done it. So now I just be treating him like I would any other acute HBV patient, which is once they seroconvert, I take them off the antiviral.
I think the second part is the whole, I just basically treat him as any kind of chronic Hep B with the whole ultrasound, checking as well. But if the answer is to treat him as an acute Hep B and convert it, then now it's technically just a core positive patient at this point. And so you wouldn't even follow with the ultrasound for long term. He's 61 years old now.
I would not. I mean, he's acute hepatitis B. We don't recommend surveillance for people with acute hepatitis B. If you didn't have data about his prior status, and I wasn't sure, if he might have been a reactivation and all those things, then I might have a different recommendation. But acute Hep B, there's no reason to do surveillance unless he has a concurrent liver disease like MASLD or MET ALD, where maybe he's got another reason for surveillance. But for Hep B, no.
He has had him long enough to having problems.
Yeah. Thank you.
Great case.
Hey guys, Wayne Fleischman. When I ask smart people this, one patient population I always had trouble managing back when I was up at the county was kind of, typical Hispanic patient with fatty liver and then AIH with kind of, either primary AIH or kind of overlap, kind of managing or monitoring response. I would always just use IgGs to be instructive. Do you guys have any tricks, or we tried to do a study to kind of look into this, but it kind of never got off the ground to kind of monitor patients that have concomitant fatty liver plus like autoimmune liver disease and kind of really kind of predict, or not predict, but really kind of manage their response? Because sometimes their ALT is never in clinical practice. Like, is it that the disease is still active? These little fluctuations, like, is there any tricks to the trade that you guys have in kind of monitoring those patients?
So the question is, monitoring people with autoimmune liver disease and MASH or fatty liver.
Yeah.
And then to get down to a point, you still know if it's noise.
Yeah, if you don't know if it's noise from their underlying fatty liver.
I think the IgG was elevated at the beginning. Oh, sorry. Thank you. You guys hear me? So loud. But he's like falling asleep.
You don't need it, Sammy.
But I think if the IgG was helpful before, it might be helpful again. But the IgG is only helpful when there's really high titers.
Yeah.
That's probably struggle with. I mean, I just look at trends, and you might have to buy or swallow liver tests of 40, 50. We know we're not going to be over 100 for MASLD. But I will also look at alcohol. There was an abstract last year at WASOD that showed, regardless of your liver disease etiology, PEth tests were high, not positive, no high percentage of individuals. But no tricks, unfortunately. I don't know if you guys have. Norm, you've been around for a while. Any in a nice way, in a professional way. But Norm, do you have any tricks you have for?
No, I don't have anything else to add.
Good question.
Being around for a while just means you've got more experience.
All right, thanks.
But I would say that I do sometimes do biopsies, and I
try. I mean, it was just hard for us to get them
actually as well, where we have like a very high prevalence of those comorbid diseases.
Yeah.
I think the IgG can be informative, and I think we use it quite a lot. But sometimes we actually sort of eventually get to the point where we go, we just need a biopsy
just to
help
figure
us.
out what's
so,
going on.
It's still a test we use sometimes for making these harder decisions.
Cool. Thank you.
Thanks to all the speakers in the panel. 2 questions regarding HCC risk in Hep B. Do the panel prefer tenofovir over entecavir because there's that little signal that maybe there's lower HCC incidence when you're on tenofovir versus entecavir? So that's the first question. And then the second question had to do with Dr. Terrell presenting that data from Hong Kong for indeterminate patients, that there was no difference in HCC incidence despite being on antiviral therapy. Kind of surprised by that based on the old Taiwan data that show, viral load being the primary predictor for HCC long-term. Of course, now, even if you have your viral load is controlled, you still have HCC risk, which is why we're still screening, despite patients who are very well controlled with undetectable viral load. So a little bit, kind of not sure what to make of that indeterminate data, because then the argument to just treat everybody then would go out the window if, we couldn't prevent HCC just by controlling viral load. So
I think that's actually the point, right? So the whole kind of, when people say treat all because we want to reduce cancer, you have to sort of acknowledge that you may not do that. And that when we are presenting the data, we're trying to do it in a more rigorous way, where we really should only treat those where we know that the treatment is translating into a benefit. That benefit might be transmission to others. It might be reducing HCC. And I think it gets at the fact that there are other things that drive HCC. And it isn't, there is the original Taiwanese study was mostly in neoantigen negative patients that were like a median age of 45, where viral load was related to your risk for cancer. Remembering that the very high viral loads, though, in young individuals, it is not, right? But otherwise it is. But remember, that there's very good data that even in patients where the virus is controlled, they still have the risk for cancer becomes alcohol, becomes MASLD, becomes other things. And that's why I think in the guidelines, we were actually I didn't get into the details, but we say if you have someone whose ALT is elevated, but HBV DNA is under 2000, you should be looking for other things that are driving the inflammation. And instead of putting them on antiviral and thinking you're doing your job, you should do the deeper dive and say, maybe I need to address their MASLD or I need to address their alcohol to drive down their HCC risk. That all said, I'm okay with putting the patient on treatment, but just acknowledging that if you're really interested in doing HCC reduction, you have to really ask yourself, what is the antiviral doing for you, and being sure you're not missing other things you need to attend to. And I think that that's what the study is showing us, that the antivirals in some cases don't help you in terms of reducing risk, may do other things, and that we really need to pay attention to the whole patient and realize that increasingly in 2026, there are other drivers of cancer risk.
Did they do a multivariable analysis in that study to control for MASLD or alcohol use? And, because that would be important.
Yeah, as well as they could, yes. It's a retrospective study, but a very large number. And overall, the rate of cancer was relatively low, as you saw. But again, not a differential in those that got treated. But this is one study. There are others you could find where they do show that antivirals seem to reduce risk of HCC. It's a very controversial area. So I think you have to do an individualized approach. But I would really encourage you to always consider other things driving HCC risk. Because there are studies, for example, where they show that in a risk factor of chronic Hep B patients, that diabetes is a bigger risk for cancer than their viral load, right? And that sort of makes sense along the MASLD pathway. So I'm not meaning to confuse you. If you want to put them on antiviral therapy, do so, but just always be cognizant that other things need to be addressed.
What about tenofovir preference over entecavir? Is there a meaningful reduction in HCC, all other things being equal?
No.
Thank you.
That's been I can't even tell you how many systematic reviews, meta-analyses have been in place. And I think the message is that there's no difference.
They all get different results.
They do. That's why there's no consensus.
I had a family member ask me this. I told them there's no difference, but she said, my hepatologist told me there was a difference to stay on tenofovir. So thank you.
Yeah, while waiting for more questions from audience, maybe I have a question for Brian. You give a very nice talk about MAD-LD. In reality, we know that too. Our patients tend to underreport or sometimes delay alcohol use, right? So the question here, we have past study here too, test here too. Could you share your experience about the utility for the past test in these patients? I think very good for the audience too.
Yeah, so, self-report is not always accurate, and there are ways to enhance self-report. I always say that The most important thing is to approach it in a non-judgmental way. Kind of the more trust you have with the patient, the more likely they're going to give you transparent information. That being said, we know that that there's a fair amount of covert alcohol use just in the general population, not specific to liver disease only. So phosphatidylethanol (PEth) is something that is really transformed the landscape, I would say, of clinical practice in the last couple of years. So it's a blood-based marker that looks at past alcohol consumption in the last 28 days. We think that if it's positive, that someone has either had recent binge drinking, or if it's not binge drinking, that it's probably more than 2 drinks per day. And it looks at it in the past 28 days. Lower than that, if they have lower alcohol consumption than that, if it's not positive, it doesn't mean that they're not drinking lower levels than that. But the value of it is that it's thought to be 100% specific. So it really binds to, ethanol has to bind to phospholipid to form it. So there has to have been exposure to ethanol. So you can have some false positives, for example, with a blood transfusion from someone who donated blood and was drinking, but truly there has to have been introduction to alcohol in the body to really form it. And that's the best value of it in my mind. Kind of ETG, other things, you could truly have false positives. So I think that's very problematic for, a test like this. But phosphatidylethanol, that's the value. So I use it in anybody who really, I'm starting the diagnosis of liver disease and they don't report heavy alcohol consumption, I order it. If someone is already reporting heavy alcohol consumption, I think there really isn't value to ordering phosphatidylethanol because, there's not much to do with the actual quantity of it. So that's the scenario I use it. It's when I'm first diagnosing someone and they don't report heavy alcohol use, or someone who I'm following over time and, really the liver enzymes don't make a lot of sense. They're reporting no alcohol consumption, but, the liver enzymes are still high, or they're not coming down, or, they have decompensation and they don't report alcohol use. Those are the scenarios where I use phosphatidylethanol.
When I was in London, Professor Sherlock, I trained with, used to say patients give you a discount for trash. So when they say they have a 2-finger tot, they really mean a 2-finger tot, or a 1-finger tot, they really mean a 1-finger tot. So I don't believe a word when patients tell you how much alcohol they're ingesting. That's the first thing. While I've got the microphone, I have to ask the audience one question that really bugs me. How many in this audience ever ask for a blood ammonia level on their patients? Could you show me with your hands?
Blood ammonia levels.
Nobody asks for blood ammonia, because I get patients referred to me almost daily with a blood ammonia. And it's a total, utter waste of money. It's a donation to the pathology department. Unless it's done resting, fasting, on ice, and immediately it's a waste of time. So please never do a blood ammonia level. Thank you.
Dr. Singh, when do you order PEth tests on patients?
Similar scenarios. I actually was going to ask the panel if you all tell your patients you're going to check the test before you check it. Because I think that there are it's interesting because I feel personally, I have not been notifying my patients, but I think that is sort of an ethical consideration and ultimately may lead to some discussions with patients.
I took a legal opinion on this, and you're supposed to notify your patient and get their permission before you do this. And even if you just say, do you mind if I do the test? But if you do it without their opinion, you can get sued.
Yeah, I always tell them. I tell them it's the hemoglobin A1C of managing their alcohol use, and that it's just a tool for me to sort of give them better advice about their alcohol use. I tell them for sure, because, I always worry that it could be, medically, legally, you could be in a difficult position, because their records are requested for some particular other purpose, and there's going to be a PEth in there that might be positive in the middle of the day, right? And people who don't understand what it really measures, I think it could really cause a great headache. So I for sure tell them. I find it very interesting for the women and men who use alcohol. They don't have alcohol use disorder, but they're definitely using, and they'll modulate their alcohol use based on their own results. So they see their PEth results come through. And once they get the hang of what PEth really is measuring and what the values, I know, Brian, you said it's not sort of quantitative, but it does, if it was 1,000 and now it's 200 or it's 50, there is a change in their behavior and they can modulate their behavior based on those results. And I find it very interesting that some of my individuals who are alcohol users do modify their behavior. So I think it's quite an interesting tool. I don't know if there's data to suggest it, but I do wonder if using PEth could actually help with modifying behavior.
I'll add that I do use it longitudinally too. So people who already report alcohol consumption and then they want to track what their progress is. I use PEth and then I show them the association. Well, you've really declined the PEth and this is what your liver enzymes are doing. And they're very encouraged by that. So I do think it's a useful tool to really show that kind of to the patient.
Yeah, I mean, it's an incredible test for unexplained liver enzymes or refractory ascites. And I don't always tell a patient, but I am very honest with them. And maybe could you have forgotten to tell me how much you drank, or could you have minimized? And I'm very careful not to be stigmatizing, but it's an incredible useful test. And it'll save a biopsy, it'll save invasive procedures, and I think it helps to educate the patients that things are not going well for them, that you stop drinking alcohol. So I think it's a great test. I think it's the best test that we've had in the past 5 years.
Another question I've got for the audience: How many of you use intravenous albumin infusions for patients with peripheral edema or ascites? Show of hands, please.
As routine, just with tapping them and
it's just routine.
Routine.
I've gone strongly against paracentesis, foreign body sepsis, and you can get renal failure. We give all our patients 50 grams low salt albumin intravenously every 2 weeks. And it's approved by the insurance companies. Oh, wow. It's amazing once you get to osmotic pressure over 4, the ascites and the peripheral edema reduce dramatically.
Yeah, but Dr. Norman, but good point here too. But studies have not confirmed it improves mortality.
No, that I agree. It hasn't improved mortality, but it's certainly short-term very beneficial.
Good to know. Thank you. Study.
Yeah, I wonder if the panel would address the choice of drugs for the treatment of metabolic liver disease. Now we have 2 drugs.
Great question. Okay, maybe start with Justin.
That's a hard question.
Yes, that is very difficult. I mean, I think this was one thing that I purposefully didn't include because I figured there might be some discussion about it. And so, I think for me, so there is a lot of lean MASH mazzled, with the diverse patient populations, especially the Asian population. And Dr. Hu, you even mentioned about, advocating for a lower BMI for those patients. I think for that patient population in particular, they benefit from Resdifra, in my opinion. I think just in terms of my internal algorithm, those patients that have weight to lose, I do think are good candidates for GLP-1s. And then this is another subset of patients that I feel like we're seeing that are younger. So maybe in the 20 to 40 range, who are overweight, who are also drinking alcohol. I think that those patients often also benefit from GLP-1s and may even benefit from combination therapy if there isn't a substantial amount of alcohol use.
I've got 18 patients who have been on resmetirom for over 1 year with a repeat FibroScan, and 17 out of the 18 have dropped the kilodalton score by at least 1 point. I'm very much in favor of resmetirom. The only time I use semaglutide is if the endocrinologist wants to prescribe it concurrently for control of diabetes or weight reduction. But I think for fibrosis, resmetirom is vastly superior. Thank you.
I use both medications, be fair balance. For stage 3, I'm very partial to resmetirom, because if you look at the data that Dr. Singh showed, the FDA approval for resmetirom is based on 1 year data, and it was based for 1.5 year data. Well, stage 3 is a precursor of cirrhosis and risk factor for liver cancer. So I'm a little under the bullet to reverse fibrosis quickly in those patients. Like Dr. Singh says, if they're overweight, have other health issues, they may benefit from semaglutide, but I might use combination therapy. Stage 2, the overweight, I think semaglutide is my go-to drug. But if they have advanced disease, I'm scared. Semaglutide is more involved. You got to titrate. So it takes monthly visits, so you got to tolerate the medication and their side effects are. Resmetirom is pretty well tolerated.
How many patients on semaglutide after 1 year are happy with their treatment? My patients have been put on by other doctors, complain nonstop, headache, vomiting, constipation, tiredness. The only abnormality I've ever had with resmetirom for the first 2 to 4 weeks is a little bit of diarrhea, which is really mashed potato stools, or a little bit of tiredness or nausea, but nothing else. It is extremely well tolerated. There are no contraindications. The dose, you've got to be a raving idiot not to get the right dose. It's either 80 or 100 milligrams, and I find it a very major advance.
But to play devil's advocate, I mean, and I agree with Dr. Gillen 100%, but, look at semaglutide, checks off the boxes, diabetes, heart disease, kidney problems, overweight, I mean, just getting to 1.7, 2.4, it takes some time, and like Dr. Gillen said, not easy.
Yeah, I'm totally with you, Sammy. If they have F3 disease, I'm interested in getting them kind of on an effective dose quickly. And that's the advantage of resmetirom, is that you start with the effective dose. The challenge with semaglutide is the titration takes time. So often it's 6 months before you're at the target dose. And sometimes I'm a little, like with the F3 plus, I'm a little nervous about that. So I also tend to move to resmetirom. But I do think the GLP-1s do offer like a lot of other benefits. And many of our patients have a lot of cardiometabolic risk. And so I like the opportunity to potentially tackle all of those simultaneously. So I do think it's individualized for sure. And what's interesting, I have some patients who don't want to go on a GLP-1 because they don't want to lose weight. I think some of my male patients, even though I think they can lose a little weight, they go, no, I don't, I'm perfect right where I am. So, sometimes they're less interested. So.
Okay, I think I would ask you one more question, take this opportunity to Dr. Briney. Thank you for sharing treatment about alcohol sobriety. For alcoholic liver disease, no problem. For MAD ALD, can you tell us more the scenario, when, how to use, because they're drinking, they're not really abusing. So how you choose patients to treat with these medicines?
This for specifically for alcohol use disorder treatment?
Yeah, for MAD ALD.
Yeah.
Not for ALD. ALD, I didn't know you're going to treat that.
Yeah. So the it's interesting, right? You think about heavy drinking, and you have this stereotype in your head of, oh, this person is an alcoholic, or they have addiction. But in fact, if you look at even not just MET ALD, but alcohol-associated liver disease, okay, that the majority of patients don't meet DSM criteria for alcohol use disorder. Okay. In fact, the majority are heavy drinkers without addiction. Okay. And really the pathology is different. Okay. So we have to acknowledge that in America, 70% of people drink. Okay. And over 10% people drink, heavily. Okay. So if you don't have addiction, which is really the consequences of alcohol consumption, and that even knowing the consequences that you continue to drink. Okay. So that's, work, health, or societal. Okay. So if you don't have that dependence, that addiction, which you can screen for by, DSM criteria, it's a checklist really. Okay. Really all they need is counseling. Okay. Counseling, and education. Okay. And that should be enough to have them reduce their alcohol consumption. If they have addiction, that's a whole different pathway where you're really treating them with cognitive behavioral therapy, you're referring them to specialists, and you're offering them medications to treat alcohol use disorder. And that's where I'm using, gabapentin, acamprosate, or naltrexone. But unless they meet DSM criteria for alcohol use disorder, I do not offer them pharmacotherapy.
Great, thank you.
I've did a survey of my patients in San Clemente, and believe it or not, 40% of all the cases I see are alcoholics, and the majority are females aged 35 to 75. Since COVID, divorce, financial problems, jobs, and so forth, I've never seen so many alcoholic amongst females. It's an epidemic. The other 40% are MASH, and the final 20% are hepatitis B, hepatitis C, hepatitis D, and metabolic disorders. But alcohol and MASH are 80% of all the patients. It may be the weather, it may be the environment in San Clemente, but it is really an epidemic.
Last chance for audience, any questions? Okay, if no question, on behalf of Dr. Asrinian, Dr. Dulai, we're very pleased to wrap our symposium by thanking the great faculty members here. By thank you all for your great attendance to the end of the symposium and the great interaction. We're looking forward to this December poster ASD in Ritz-Carlton. Thank you all.